Hey there, in this video, I basically combine all of the top resources that we've created for step 3 and put them into a singular video. And so this is completely free, but basically we'll go through the ultimate guide where I'll show you exactly what you have to think about, how step 3 is set up, exactly how to approach each case. Then there's 4 case walkthroughs, so you can actually see how I go through the cases. After that, we have high yield risk factors, which are the things that you'll see primarily on day 2. There's an ethics section and a biostats section. And so biostats and ethics are very, very high yield for day 1. And so between all of these topics, you should be absolutely covered for step 3. It's a very long video, so I would just use it as a big resource and come back to it as you need. My name is Milani. My only goal is to help you study for step 3 faster. And so I hope this video helps you. If you have any questions, feel free to drop them in the comments. This is a comprehensive, updated 2026 guide on how you should approach the CCS section of Step 3 and absolutely ace it. The goal in this video is to help someone who has no idea how Step 3 works, how CCS cases work, all the way through people that are very good at the cases but are just trying to maximize their score and get that final little bit. For background, my name is Milani. I'm a current NYU resident. My absolute big picture goal is to help everyone study for step 3 and pass it or ace it in as little time as possible. And so through these videos and through StudyCCS, our goal is to really help you be as prepared as possible for testing. In terms of this video, what we're going to do is we're going to first go through just background on the CCS section, how it's different from step 1 and 2, and things that you should absolutely know. Then we'll actually go into the interface, how each button works, how to push yourself through a case. Then we'll go into how the cases are actually scored. And this is really, really important because this is where all the points are. Then we'll go into the types of cases that you'll see. Then we'll have orders and mnemonics, which are really important because ultimately your entire score comes from your orders. Number 6, we'll go through tips and tricks that will absolutely save you minutes, which are very, very precious on these cases on test day. And then number 7 is the actual biggest mistakes people make. And so the way I want you to think of this is as a buffet. With any buffet, you want to kind of get a quick glance of everything that's going on, and that's what this video is going to be. And then whenever you need to refer back to it, you can either refer back to your screenshots or refer back to those points in the video so that you can absolutely nail those weaknesses that you have. In terms of Step 3 and CCS background. So Step 3 recently changed in March of 2026. And it changed it from not only being different from step 1 and 2, it also made a lot of the interface different and all that. So there's another video here if you want to check that out. But big picture wise, the way it differs from step 1 and 2 is, first of all, it's a 2-day exam. Day 1 tends to be more like step 1. So you'll have a lot of mechanisms of action. You'll have a lot of ethics questions. And then day 2 is more like step 2, where you'll have a lot of clinical questions, prognosis, risk factors, things of that nature. Additionally, the CCS section is on day 2, and all of it is on day 2, whereas day 1 is only the multiple choice questions. What makes it different than the multiple choice questions is multiple choice question, if you get it wrong, you get it wrong. Where with CCS cases, I like to think of it almost as some of our like general biology classes where you can actually get partial credit. And so similarly, on those exams, I remember writing as much as humanly possible just so I could get partial credit. And so CCS cases are very similar, where you can order all sorts of things in order to pick up partial credit in the little nooks and crannies of the cases. And so while everyone is very afraid of this section because they have so much practice with how step 1, step 2 were, and this is completely new, I would argue that with the right systems, you can actually look forward to this part of the exam because you'll know exactly how to approach it. In terms of just like common fears, I think people are very, very concerned about the software. I like to think of it as like CPRS, which is the VA software, very, very different EMR, and it just takes time to figure out how to order the things that you want to order. But we'll walk through the software. People don't know what to order, and we'll go through the systems for that. And once again, very important to have systems, because if you don't have a system for these cases, you'll really struggle with actually remembering what orders you need for what types of cases, what patients need what. But with a good system, you'll be able to master that very quickly. And then once you have that, then you can just work on your knowledge base of different tests for different workups for different orders. Then running out of time. This is actually really, really concerning for a lot of people because the case is, if you don't know what's happening, you're just kind of freaking out and the timer's ticking down and you don't know how to get the orders in. And so I'll go into lots of tips and tricks in chapter 6 of this video so that you can really master that part. But I really want you to just take away that the CCS section is a very gameable part of step 3. So with the right systems, you can absolutely nail it. So now we're actually going to go into the interface, and I'm just going to pick a case from here. So within the interface, once you start a case, what you'll first get is a case introduction. It'll give you a time. It'll also tell you just basically the one-liner or the chief complaint of why this patient's coming in. And then you hit OK. And so now you get some initial vitals. And then after that, you'll actually get an initial history. And so with the history, you can kind of hear what's been going on and just updates that may be relevant to the case. Very important to spend a minute to just really understand what's going on here. Oftentimes from the history and just the chief complaint, you have a very strong idea of what the diagnosis is, and just knowing exactly what that looks like will save you a bunch of time later. Now I'll hit OK, and what it automatically does is first you'll want to go to the 4 sections at the top and just understand those. So here you have interval history or physical exam. And so here you can select the parts of the physical exam you want. And the way it works is anytime you select a part of the exam, you'll hit OK, and then it'll tell you how much simulated time it'll take. So like any simulation, to do a part of physical exam, it takes time. And so you do that, and if you hit OK, then you'll get the results of just that section of the physical exam. And it'll advance the timer accordingly based on how many things that you did. So not every patient should get a full physical exam. If someone's coming in with a pneumothorax, you want to treat the pneumothorax before you do a rectal exam on them. And so very important to realize that these simulations, it's important to know exactly what you want to do for each patient. And we'll get into tips and tricks in chapter 6 of this video. So now we hit OK. And here you can see the simulated time advanced. And here is actually real time. So at the top, it'll tell you how much time you have. And so here right now, you can see that it was a 10-minute case. We have 9 minutes left. And here we have 1 minute. We've already done a physical exam. Majority of the sauce is in this orders tab, particularly on this orders subtab. Here under progress notes, you'll actually see the various pop-ups. So progress notes is basically the pop-ups that show. And if you forgot them or you want to revisit them, you can check it. But big waste of time having to come back to it. So it's better to spend an extra 10 seconds and read it properly than to come back to it. For vital signs, you'll see it here, lab reports, imaging, and all of this imaging, other tests will happen based on the orders you put in on this page. Before we get into some orders, this is the clock. This is how you move the case forward. So if you don't advance the clock, you aren't able to move the case forward. And I'll show you exactly how to do this with orders very quickly, where once you put in some orders, you can either move the clock to a particular time of day, or you can tell in how much time you want it to be moved forward, or the next results. Let's say you ordered a CBC, CMP, EKG, and you just want to know as soon as you have the next result, you can do this. This button is arguably one of the worst buttons that exists, and I would only use it in very particular cases, which we'll get to later. And then we'll call/see me as needed. This is actually very helpful because anytime you get a result, a lot of the results will populate very quickly. And after each result, you have the option to stop and put in more orders. And so you don't have to fully jump through all of the results just to actually access this. And you'll see this once we do the orders. So the clock we talked about, and now this last one is very important at the beginning of a case. Let's say someone comes into the office and they have chest pain, radiating to their shoulder, 8 out of 10. At this point, you don't want them to be in the office. You want to change their location. And so based on where they're at, you can place them in any of these 5 locations. So if someone's in the ED and they need to be to the ICU, you can escalate them. If someone's in the office, you need to escalate them to the ED, you can do that. So really important. And once again, we'll go into exactly how to use this shortly. I just want to walk through this big picture. Now when it comes to orders. So the way orders work is orders is the most important thing. I'm going to hammer this home, and I really want you to understand this. Your orders matter. And just like whenever you're admitting a patient, if it's not ordered, even if you thought about it, you're not going to get points for it. And so, for example, let's say we do a CBC, CMP, EKG. So with this, if I hit confirm orders, then what it'll do is it'll search the database and then it'll find the order. So CBC, you can actually type a CBC. Some things you cannot. For example, if you want to do a lumbar puncture, you cannot type LP. It will not show up. And so half of this is understanding the interface and understanding what you have to type in order to get the order that you would like. But CBC, CMP, and then EKG actually shows cardiac monitor as well as a 12-lead EKG. Very important, and I'll get into this in the orders and mnemonics section of this video because this is where you can save a lot of time and get a lot of important data that you might need and can actually get a lot of partial credit for a lot of cases. But let's say 12-lead. And then once you do this, you'll confirm them. And once you confirm it here, you actually can see when you'll get that result. So for example, you'll see that an EKG you can get within 15 minutes. A CMP takes about an hour. And then a CBC takes about 30 minutes. And so each test takes a certain amount of time. So for example, if we were to say, call me with the next result and we hit OK, then you'll see the result. But if you want to actually see all of them, you want to be able to actually see, you want to do call me and see me as needed. Because if you hit this, then it'll actually show all of the results. And so now we have that. And you understand roughly how the interface works. So the way these cases work is if it's a 10-minute case, then you'll have 8 minutes to put in all the orders, see the results. And once again, the results are supposed to guide your next set of orders, but you only get scored for the orders. After that, you'll have 2 minutes to put in additional orders. And whenever we go into the orders scoring section, that's where you'll see the kinds of orders you need there. But it'll be mostly preventative care, health maintenance, setting up follow-up appointments, stuff like that. Very, very important that you just understand how this interface works and how the setup is. If you have a 20-minute case, it's very similar. 18 minutes is for the case, and then the last 2 minutes is for these additional orders. For the additional orders that you put in this time, you don't get a result for them. And so it's important to know that that section is either to gain extra points or to put in orders that you shouldn't waste time on right now. So now we've gone through the interface. Now let's actually go through how the cases are scored. So for the cases scored, what you'll notice is that we have about 13 or 14 cases on the exam. This means, and the overall section is about 25 to 30% of your total step 3 score. That means about each case is around 2%. And so the number one mistake people will make here is they'll get caught up with like, oh no, I got all these negative updates. Negative updates are if a patient continues to get worse. A patient with a pneumo, for example, if they continue to get shortness of breath because you're trying to get a CT scan on them, it's totally possible and you have to actually address that. And so they'll say, oh, patient's getting worse, patient's becoming more hypoxic, patient's becoming more short of breath. That's a negative update. If you do something right, you'll get a positive update where, for example, if you saw that they have a pneumo and you do a thoracentesis and then you place a chest tube, then the patient will get better. And so patients are starting to feel better. The pain has subsided from 10 out of 10 to 4 out of 10. And so all of these things really matter. You don't want to get caught up on any case. You want to be able to push through the cases. Now, like I've said repeatedly, and I really want you to understand this, your orders are the only thing that matters. You'll do physical exam, and you want to maximize the physical exam, which in the tips and tricks section, I'll tell you exactly what to maximize, but the orders are everything. So if you don't include an order, you don't get points for it. And sometimes, not only are you trying to put in orders to diagnose something, you also want to rule out other things, and you want to manage things. And so whenever it comes to the order categories, they come into 4 different categories. There are diagnostic orders, there's management orders, there's preventative care / health maintenance, and then there's inappropriate orders. For example, a diagnostic order for someone with chest pain could be an EKG, a chest x-ray. A management order would be taking them to the cath lab. If they have a thora, it would be doing the thoracentesis. And then a part of management / diagnostic is also post-care. So for example, you do a chest tube, you place it, you want to get a chest x-ray after. And so it's important to not only get the orders, but also do the things that you would do in real life, because those also count for points. And then preventative orders / health maintenance. For example, let's say in the HPI or the social history, you find out that the patient smokes. So you want to instruct or advise them on smoking cessation. Very important because you'll get points for doing that. Similarly, alcohol cessation. All of these things will go into, once again, in the orders and mnemonics section, just so you don't miss anything, but I want you to just be aware of what's going on. And then inappropriate orders is, for example, you have this person with chest pain, and you go to the location section, and you say, send them home. If you send them home, that's a very inappropriate order, and you'll actually lose points for inappropriate orders. Typically, you'll get more points for getting the diagnostic and management orders than lose points for the inappropriate orders. And I'll tell you exactly when you should escalate your care. But if someone comes in with belly pain and you say intubate them, you will lose points for those inappropriate orders. Now, in terms of what actually matters. So you want to treat the symptoms early. So if someone's having pain, you want to give them morphine. You want to give them Tylenol. You want to be able to treat their pain, their symptoms. You want to also stabilize them. Very important. If someone's hypoxic, toss oxygen on them. You want to monitor after intervention. So for example, like I said, get the chest x-ray after you place the chest tube. Right orders, right time is very important. So for example, and you have to understand the software here is made by the USMLE. And so it's not incredibly sophisticated. And the fact that you can only place each order once, for example, you're diuresing someone, and so their potassium is low. You'll give them potassium, but you can't order potassium twice. And so what that means is that actually your goal is to just place all of the orders. And so right order, right time, and then preventative care. And so follow-up appointments, instructions, vaccines, screenings, all of those are very important. What loses points are harmful, contraindicated orders, doing it in the wrong sequence, delaying critical treatment. So for example, if someone has an abdominal aortic rupture or aneurysm rupture, then you want to be very aggressive in those situations. And so if you don't address that in a timely manner, you will lose points. You have to monitor them after treatment, avoid the invasive procedures that we talked about, and then you want to make sure you don't miss parts of the physical exam. And I'll tell you exactly what parts of the physical exam to do for what patients very soon, and just so you don't have to think about it. But once again, big overview first. Key takeaways are your orders are everything. And whenever I think about this, the way I think of it is even the results of the orders don't matter much. Simply just having the orders makes a big difference because the results help guide you. So until you figure out the diagnosis, you want to look at the results and understand it. But if you know someone's having a COPD exacerbation, the best thing you can do is just shotgun all of the orders that you need for that COPD exacerbation so you get the points rather than waiting. And so you want to get your orders in quickly and effectively. Overall, non-harmful orders won't hurt you. I like to think of this as a perfect world where you can order everything and no one's going to really yell at you. There's no financial consequences. And so if you don't know what antibodies to get for a room workup, order as many of them as possible. And the way the system is set up is a lot of orders are linked on the back end. And so, for example, various stool studies, you can actually pull them. It'll lead to the same like stool, ova, and parasites, but it'll be listed in different ways. And so just click on a bunch of them. And then once you see them, then you can go from there. Similarly with oxygen. Oxygen therapy is listed as oxygen as well as oxygen therapy, but they both go to the same order. So if you click on both of them, it'll say you already ordered this, you can't order again. You said okay, and then you move on. And so it's better just click on a bunch of things and then just say okay and move on later. Only the very harmful orders will subtract points. And so my rule of thumb here is if someone's order or if their case is not getting better, they keep complaining or of headache, shortness of breath, go more invasive. So for example, if you got a chest x-ray, it didn't show anything, get the CT scan and call the consult. And what it does is it's almost a sign that you're not being aggressive enough. And so anytime this would happen, I would just go way more aggressive. I want you to know that getting the diagnosis typically isn't the hardest part. You can figure out the diagnosis pretty quickly. The harder part is actually getting all of the orders in quickly and making sure you don't miss any orders. For example, if someone's coming in with chest pain and they have a clear STEMI on their EKG, you still want the chest x-ray. In real life, the ED will probably still get a chest x-ray, but if you're not used to being in the ED, chest x-ray will let you know if they're having pulmonary edema. It'll tell you other things. It'll also just rule out other things. And so it's really important to do all of the things that you would. Or for example, new onset AFib, you want to get the TSH. And these are the places where a lot of people lose points. And this is why the mnemonics matter. And we'll get to that very, very soon. And then preventative care, this is all like free points at the end. They don't make as much of a difference. But if you have done the whole case and now it says you're at the 2-minute warning, put in your additional orders, you have 2 minutes to just crank out as many additional orders as possible so that you can maximize your score. Next chapter is the types of cases. Whenever I see a case, the first question is always sick or not sick. And this will kind of tell you where to go. And the way it works is you only go upwards. So you'll have a sick person in the office, you'll send them to the ED. If you have a sick person in the ED, you'll send them to the ICU. If someone's in the ED or in the office for acutely decompensated heart failure, then you can send them to the floor. And so there's various different situations where you'll escalate the care, and it's just important to realize that. Also, knowing sick or not sick will let you determine which parts of the physical exam you should do, and basically how much time you should waste on that. If they're in the office, it's like a well visit, then you can do a full physical exam. If someone's acutely, short of breath, you don't want to do the rectal exam. So very, very important to look at this. You can screenshot this, but very important to know the kinds of cases and where you'll put people. So for example, if someone's very unstable, send them to the ICU. These are oftentimes the big conditions you want to send them to the ICU with. If someone's has a pneumonia, CHF exacerbation, COPD, cellulitis, pyelo, pancreatitis, DVT, sickle cell crisis, bowel obstruction, new AFib. These are like typically floor patients. Office to the ED is often chest pain, new onset seizure, acute abdomen. And these are pretty easy to figure out. If the patient looks like they need an IV and IV antibiotics, just admit them because it's much safer than you trying to work it up outpatient. The other thing is in an outpatient visit, the system tries to make you send them home. So if you order a bunch of tests and maybe one of those tests will get done in 6 hours, it'll say, okay, patient wants to go home. Do you want to send them home? In that situation, you don't want to send them home. And so what you can do is send them to the ED and then you won't get that patient wants to go home message, and it saves a lot of bit of time. But in the office, you'll have a lot of well-child visits, prenatal visits, depression, anxiety, stable COPD, PCOS, obesity, things of that nature. So just important to understand the different types of cases you'll have and then how to handle the severity. All right. Now, this is the section that makes a massive, massive difference because this is the orders and the ways you remember those orders, and the orders are what get you the actual points. So we're going to go through this section step by step. As an overview, these are going to be the big ones. And then at the end, I'm actually going to go give you the orders that you should consider for the different types of patients. So if it's a cardiac case, if it's a pulm case, if it's a neuro case, what you should do. Okay, so the first one is CAMO. So CAMO is, I think of this, I grew up in the South. A lot of people wear CAMO. And so I think of it as you walk into every room wearing CAMO. And so cardiac, ACC, morphine, and oxygen. Now, cardiac is cardiac monitoring EKG. And you actually saw this earlier. Whenever I typed EKG, it actually pulls up cardiac monitoring and EKG. Similarly, ACC gives you AccuCheck, which is basically a finger stick glucose and an IV access. Morphine, you can place morphine, and a lot of patients, it's okay if you give them morphine here, or you just give them Tylenol, ibuprofen, whatever. And then oxygen, if you type in oxygen, you get 3 orders. You get oxygen therapy, pulse ox, and blood gas. Let me just show you what this looks like. So you come here and you type EKG, you type in ACC, and you type in oxygen. So what you do is confirm orders. Whenever you confirm, you'll see cardiac monitor and a 12-lead EKG. So if you click on both, you'll confirm both of those. So you just knocked out. You don't have to search everything. You can search it by one fewer click. Similarly here, you have IV, and then you have glucose. And then oxygen, you can do oxygen therapy, blood gas, and pulse ox. And so now you have all of these very, very important orders already lined up by just searching for things. The next one that I remember is 3C, 2U, PLT. And PLT as in like platelet, but not actually platelet. But if you want to get it, it helps you remember to think coax. So 3C is CBC, CMP, chest x-ray. 2U's is UA and urine drug screen. And then PLT is pregnancy, lactate, TSH. And then once again, if you want to get platelets, you can always add those, but these are basically the ones that I get for every single person, even if I am not thinking about that person at all. And I'll show you a secret on how you can shortcut this by actually copying and pasting in a little bit. But these are the very, very big ones that you should absolutely order almost for everyone, just because you'll pick up things that you wouldn't have gotten otherwise. For example, there are cases of patients, even pediatric patients, that come into the hospital not feeling well, and then you do a urine drug screen and you see cocaine. And so stuff like this happens all the time. And so ordering this on every single patient, very, very helpful. And then there's various case dependent ones. And as you read the case, if you have this copy pasted, which I'll show you how to do for exam day, then you can also just add additional ones with your initial bulk order set. And so if someone looking infectious, you'll get blood culture, you'll get urine culture, you can do RVP, things of that nature. Fluids is another one, very important for a lot of patients that are coming in. The only thing with fluids is you want to be a little careful, because if they have a bunch of pulmonary edema or they have a right-sided or left-sided STEMI, you don't want to give them fluids. And so you have to be a little careful in who you're giving fluids to. And then drug level. So the other one that I'll get with drug, oftentimes if you just type in drug, is you can get urine drug screen and serum drug screen just to help rule it out. For cardiac stuff, you want to get troponin, BNP, even a CHF one, or a clear acutely decompensated heart failure, or even if it doesn't sound acutely, just get the troponin, just because you don't want to lose these easy points. And it sucks if you try to use too much of your clinical knowledge and they're not using it. And so now you're losing points because they are less sophisticated than you are, obviously. Now, the next one I like to use is my admitting orders, which is AIDLE. So activity. So if you type in activity, you can tell what kind of activity. IV fluids, we already talked about, but if you haven't done IV fluids, you want to probably give them at least a bolus. Diet, you can determine the diet. Typically, the diet one that's most important is if they're about to go pre-op as well. And so, signifying that they should be NPO. One that is very, very commonly missed is the low molecular heparin. And so you want to do DVT prophylaxis, and then you can do ins and outs. And so you want to type in ins and outs, vitals, and then if they need additional tubes, then you can place tubes, right? Foley, things of that nature. Surgical orders, also very, very important. A lot of the cases will need to go for surgery or consulting surgery. And so the one I use is TPN ACSF. And so T is type in screen. P, I think of it as basically coag, so PTT, PTINR. N is NPO. A is antibiotic. Oftentimes you can just do cefazolin. C is consent, very, very important. Surgery name, which is what procedure. And oftentimes you'll have put in this procedure thing first, and it'll end the case. As soon as you put in some orders, it'll automatically end the case. And so then in those final 2 minutes, not only are you trying to do preventative health stuff, you're trying to get in all of these other orders that they'll need for surgical, and then fluids. Now, for the last 2 minutes, a lot of times the vaccines, the patients are pretty up to date on, but you want to just make sure that you don't miss this. And so it's very easy to just type in vaccine. And if you type in vaccine, it'll pull up all the vaccines. And what you do is you just think about it for pneumococcal. You want to get that for patients above 65 or have the right risk factors. You want to get the meningococcal, the influenza, shingles, Tdap. Basically influenza, Tdap. I get it on everyone, even if they say their vaccines are up to date, just because I don't want to lose points. And then counseling. The biggest ones that you can get points for, there are a lot of counseling that you can do, but they'll say they got a colonoscopy or their mammograms all up to date. But the biggest ones are smoking and alcohol cessation, because these are common risk factors for a lot of the cases. And so you lose points if you don't include them. And so you absolutely want to do this. Safe sex is also very important for a lot of the young patients that say that they occasionally use condoms and things of that nature. And so basically having your butt covered with that counseling. Oftentimes the order for that, we'll get to it, is advise or instruct. And then seatbelt use is a good one. But pap smears, mammograms, colonoscopies, DEXA scan, these are just like the age appropriate ones you want to think about. Now, a lot of this stuff is like things that you're aware of, but you see the case and you just like forget an order. And so important to just do cases of this, and that's where StudyCCS is very good. One thing that's really important whenever you're doing cases is once you figure out the platform, it's actually more important to do cases quickly because you're just trying to get the reps in. You don't really care about how you do on your practice as long as you're ready for test day. And so one thing that we have here that I think is actually very helpful is the speed order game. And what this does is it allows you to pick a patient here and you can write it. And you'll see a lot of the information. So it just basically saves you time on the case because you don't have to go through the whole flow. And then you place a bunch of orders. You do CBC, CMP, CMP, and you get all these orders. Then you hit reveal diagnosis. The diagnosis pops up, and then you put in more orders. So put in all of the orders that you could possibly do. And so what it does is it trains you on how to group your orders very closely so that you get very good at putting in all the orders. What you want to do is, for a lot of these cases, you want to get in the habit of putting in a lot of these orders very quickly and just not missing them. So for cardiac cases, troponin, BNP, echo, lipids, A1C, aspirin, heparin, nitro, beta as in beta blocker, you can type in metoprolol, statins, cath, cardiology consult. So these are the big ones for cardiac ones. For infections ones, there's blood cultures, urine cultures, sputum, wound, CSF, lumbar puncture. You can always consider if they're not getting better or if you have a very high suspicion. If someone has like very clear young person that comes in with meningitis, you also want to think about prophylaxis for other people. And so advising about that is also an important order. So if you type in advise, then it'll say basically like contact precautions effectively for like family members and friends. Vancomycin, ceftriaxone, piperacillin. I typically would do vanco and cefepime because they're easy to spell. And if you type in vanco and cefepime, they show up. Piperacillin, you misspell it. You don't want those kinds of problems. For GI, stool. If you just type in stool, it'll pull up a bunch of them. So you can get so many stool studies by just typing in stool and then click on C. diff stool, culture, ova and parasites, lipase, LFTs, CT abdomen, ultrasounds. You'll order a lot of ruckuses actually. Just because if someone's complaining of pain there, you'll get the ruckus, it won't show anything, and you'll get the CT scan too. But it's helpful to do the ultrasound just because you don't want to lose points for that. Type in screen, NPO, GI, and if you need to do something, you want to call a surgery consult. For POM, albuterol, ipratropium, I would do steroids, D-dimers, CT chest, sputum, intubation, mechanical. Another thing here, we'll go into this, but if you're going to intubate someone, you need to have an intubate order, a mechanical ventilation order, and an oxygen order. Oftentimes, if they're hypoxic, you'll have already slapped on the oxygen, but you don't want to miss these two. For neuro, you want to get a CT head and a CT angio, MRI, alteplase, a swallow eval, lipid, A1C, coags, neurology, aspirin. And then OB-GYN, you want to think pregnancy, ultrasound, RH, magnesium, labetalol, methotrexate, OB consult, psych, urine drug screen, alcohol, suicide. You want to also make sure you call your consult. And so you're seeing this, but with psych, sometimes you even want to just put in a social work consult because it can be very helpful. SSRIs, benzos. So, and then lastly, you have your endocrine metabolic ones. And a lot of patients, I'll get the TSH. That's a part of my 3C2U PLT. And so it's helpful to get, and it's something that I would forget frequently. And so I included it in just like my system of how I would shotgun a lot of the orders. But these are the other orders. So we've gone through all of the orders, and you can always refer back to this and check it out later. In terms of tips and tricks, very, very important to use these to get the best score possible. Couple of things that are very, very helpful that I think a lot of people need to do more frequently. First is use the sheet of paper as you do the exam. And so this is what I talk about prep. So the exam gives us a lot of leeway. We can access our locker. We have, even during the multiple choice section, a lot of time to actually just like write stuff down. So if you finish a section early, you can write down your various CAMO orders. You can write down all of your cardiac orders, your pulm orders, and then this becomes a mental checklist and a physical checklist for you. For whenever you get to the CCS cases and you have a cardiac patient, you can look down and be like, oh, I left out the echo. Like, I should make sure I include that. And so that's very, very helpful. Other thing you can do is you can also use these cheat sheets. So you can print it out and then keep it in your locker, look at it before, and then walk into the room and jot it all down. And the ability to take so many breaks means that if you like aren't able to jot it down in one, you can jot it down after another break. I wouldn't recommend doing this if it would stress you out. Like, do whatever will keep you calm, but like if knowing you can write all of it down gives you a lot of solace, I would definitely do that. So use your scratch paper, basically. The other thing that you've kind of gotten so far is the way you search for things is your best friend. So that's order search bar. Like, for example, for an autoimmune workup, I would just type in anti, or if I don't remember vaccines, you just type in vaccine and it'll pull up all of them. And so there's no point in you having to worry about exactly whether you know the correct workup for this like rheumatologic thing. If you can just order a bunch of them, click on them, and if you've already ordered a similar one, it'll tell you that, oh, you already ordered this, you can't order again, and then you just hit OK. This is way, way faster than trying to recall which things you need to order. Similarly for stool, you can write stool. Culture is a big one. Counsel, instruct, advise. Those are three big ones here. CT, MRI, screen. A lot of these you can get really easy points even if you don't remember the exact test by just writing that. Now, a couple of things that are also helpful is writing the diagnosis. So for example, if you don't know what thing you should order for a stroke workup, or if you're just trying to maximize your score, just type in the diagnosis, type in stroke, type in for patients that come in with rape or abuse. For those, if you type that in, you'll get a bunch of different orders that you may not have gotten points for because you didn't think that you had to reach out to the abuse hotline or things of that nature. So very, very helpful here. And then oxygen is another one that you saw very early on. You get multiple orders for that speeds up the process of putting in a lot of your shotgun orders. Okay, copy pasting your orders. So what I did on my actual test day is if I finished a block very early, in any multiple choice question block, there's a little notes button. I've never used the notes button in my life, but here you can jot down all of the orders that you want. You jot down CMP, enter, CBC, enter, and then you copy it. And then what I would do is I would actually delete it and then hit paste just to make sure that it pasted. And if it pasted, now that means that's already on your clipboard. And so whenever you get to your first CCS case, you can literally start the case after you do your physical exam by just pasting. And I think that is a big, big benefit that saves you a bunch of time. You don't have to worry about missing a lot of these like common things in the beginning. And what it also allows you to do is, since you're not thinking about all these orders that you're putting in for every patient, as you read the history, you can actually think of other orders you want to add to that list. So if they're looking more infectious, you put in your infectious ones. If they're looking more cardiac, you put in your cardiac ones. Saves a bunch of time and a lot of just like mental space. Now, physical exam. Very important as well. The way I think about this is if there's an urgent case, so they're looking very, very sick, and it's clearly not GI, what I do is I check the top two. So I do general appearance, skin, hint, chest and lungs on this side, and the top two on this side. So heart, abdomen, extremities, and neuro/psych. So I'm leaving off these middle four basically. And what this does is it allows you to do a targeted physical exam effectively without missing a lot of big things. If it's GI, then what I do is I do the same top two on this side, but then I do this whole right side, because it's possible that GI symptoms are secondary to rectal or genital. And so very important to just like do the whole side. And then if it's anything else, not urgent, just do the whole physical exam, because you won't lose points for doing a lymph node exam or a breast exam, but you can definitely lose them for not doing it. So very important, just do everything there. Clock management, we kind of talked about this. For a lot of the sick ED patients, I would just do call/see me as needed. For the inpatient ones, I don't like to advance it more than a day at a time. For example, you'll have acutely decompensated heart failure and you're giving them Lasix. Maybe on day 2, there's an automatic update if you put in the Lasix order that the patient's starting to feel better. And if you didn't put in the order and you say, let's skip ahead to 4 days from now, you could actually run into 2 negative updates. And so anytime you get a negative update, you want to quit your jumping ahead process. You want to stop right there and you want to put in more orders. And then for outpatient, whenever you're doing outpatient, for example, an MRI, it gets done within like 24 or hours. So outpatient, I also don't skip more than like 1 or 2 days. And so I'll just jump ahead 1 or 2 days. We'll have a lot of the results and then you'll talk about it. If you try to do call me/see me as needed in an outpatient patient, it will not work that well, because what happens is a lot of the tests take an hour. And so the patient says, I'm going home. So you don't want to do that. Like I said, very, very important. If negative updates are showing up, that means you're missing something big. So that means either escalate the type of imaging or management that you're doing, or you're just like not treating their pain. But majority of time, if you use our CAMO method, you'll already have addressed their pain or shortness of breath. And so whatever you're missing is typically a management problem. And that means you need to increase your diagnosis, like invasiveness of your diagnosis, or your threshold for managing or treating something. Similarly, if someone's not getting better and you're like scared that you're going to lose points for intubating, just like put in intubate. You'll lose maybe some points if it's wrong, but if it's correct, you'll get way more points. So if you're getting negative updates, just increase the intensity of everything. And then consult. After you put in a consult, it actually asks you to write a little blurb. I would not waste time on this. There's no chance that the USMLE is looking exactly what is written and scoring based on that. And so just like jot a very short thing. For example, like neuroconsult, stroke. Like cardiac consult, STEMI. Like I would, even for surgery consult, you can write a COLI, or I would literally just write COLI, because it's not going to change your scoring. And then really, really use the last 2 minutes. If the way I think of the last 2 minutes is in an urgent case, the last 2 minutes are for all of the other orders that you may have missed because you ended the case. Like, for example, you put in the chest tube for the store, the patient's feeling better, but you didn't ever get basics. You never got a CBC, CMP, even a blood gas. And so now is really want to focus on those. And if you don't get to health maintenance, that's okay. On a healthy patient that you finish the case, everything's beautiful, you really want to focus on getting all the health maintenance stuff. Colonoscopies, all of the alcohol cessation, stuff like that. And just like software quirks, like we said. So majority of orders need at least 3 characters or letters. So for example, the only order that works with 2 is a UA, but like LP will not work. You have to type in lumbar or lumbar puncture. Like I said, intubation is 3 orders. You have to intubation, mechanical ventilation, and oxygen in order for that to work. And then duplicate orders is you want to make sure that you just like spam a bunch of orders and you won't get any penalty if you order it twice. So we've gone through a lot of stuff, and now I just want to go through some of the biggest mistakes people make. The number one biggest mistake people do is they go too slow. And that's why I'm talking about the speed order setting here as being so helpful, is because you build the instinct of all of the orders that you need a shotgun for various different types of cases. Once you figure out the shotgun orders for every case, you just want to see as many cases as possible so that you can get as many different types of cases exposure without wasting all of this time on pushing yourself through the software. Frankly, in 10 or so cases, you'll understand the software very, very well. However, where you won't be able to figure out is if you never saw a patient with pelvic inflammatory disease, then you may miss orders there. And so it's way better to do more cases just with the speed order setting than it is to just wait and try to do fewer cases and just really understand the software, because the software you'll get within 10 cases. Very important to obsess over the orders instead of the results. There's so many results that I do not care about. I'm just putting in the orders because the orders are important. For example, if I think that someone's TSH could be high, maybe it's not high, I don't care. I'm just trying to spam a lot of the orders. So really focus on the orders. The other part about orders is you really want to make sure you're ordering everything. Even if you think there's a low likelihood of someone having, a PE, just get the CTPE if they're acutely short of breath and you've managed everything else and nothing's showing up. Just order things because it'll make a big difference. Similarly, don't be afraid of ordering invasive tests. You will lose way more points by being too safe and not really giving them the full workup or being as invasive as you need, versus just holding on to these invasive tests and not actually ordering them. So don't be afraid to use them. Don't get stuck on one bad case. There's so many people, if you ever go to Reddit, they'll be like, oh man, I got all these negative updates. And then after that, they were just thinking about that case. Move on. Each case is its own thing. And the thing is, even if you don't know the diagnosis, you can spam so many orders to get the majority of the points. And so if you use the system that we talked about here, you don't have to worry about always knowing the diagnosis. If you know the diagnosis, that's fantastic. It'll help streamline things. If you don't, a lot of the workup for a lot of these chief complaints is still the same. And so just send out stuff until you start getting positive updates. Really, really important. Practice learning the cases without the orders. Like I said, once you know the order or the interface, it's just way more important to know what you have to type in order to get all of the orders that you want. Don't skip preventative care and follow-up just because you'll get so many easy points here. And those easy points will just reduce the need for you to do very well in the multiple choice section. Don't panic if you have an unfamiliar case, because once again, the system will carry you through. You'll get majority of the points. Even if you get an 80% without knowing the diagnosis, that's better than getting a 60% when you know the diagnosis, but you missed a bunch of orders. And don't advance the clock wrong, because whenever you advance the clock wrong, you can force a negative update. And so you don't want to force a negative update because you lose points every time you get a negative update. And that was our total comprehensive CCS case class. If you made it this far, I wanted to give you a special gift. If you use the code STUDY, whenever you're checking out for StudyCCS, you'll get 20% off. I'll make sure that this always stays active. But this is a very, very reasonable exam, and the CCS section can actually become your strongest section very, very quickly. And by doing well in the CCS section, then you can bomb the rest of the exam and it'll carry you through. Thank you so much for checking out this video. Feel free to reach out if you have any questions. Hi, my name is Harsh Milani. I'm a current NYU resident, and today we're going to go through a CCS case from StudyCCS for USMLE Step 3. So this is going to be about chest pain. And as you know, there's 10-minute cases, 20-minute cases. There's a video where I break down exact interface, how to get through it. But I just want to show you how I actually think about the algorithm, how to maximize points in a case that's emergent with someone that has chest pain. So here you'll get the one-liner. So they're coming in, substernal chest pain. And then you have some vitals. Vitals are very important because it helps you triage. Should they stay in the ED? Should they go to the ICU? If they're in the office, here we know they're in the ED, but if they were in the office, should they come to the ED? And so that's one of the earliest decisions you should make. Here we can see they're concerned for some ST elevations on the pre-hospital ECG. So maybe they got that in EMS. Here it's substernal chest pain, elephant sitting on chest, 8 out of 10, diaphoretic. Okay, so it seems like this person may be having a STEMI. We don't want to fully anchor because oftentimes they can have other things. Maybe there's the complexities not just in the STEMI, but all the orders we have to put in. And so let's get ahead of this. Oftentimes on the physical exam for emergent cases, just top 2, bottom 2. The only exception for this is if it's an abdominal pain and you want to get genital and rectal, but otherwise top 2, bottom 2 will get you very, very far. And so we'll do okay, we'll hit okay. And all of this is just to help us understand what's happening, but all of the points come from the orders. So we have to really focus on the orders. So here we got, okay, pretty cold, clammy. Neck is okay. Chest is, they're moving. Lung is okay. even cardiac is okay. So it's not atrocious. That's always a very good sign. Now let's put in orders. For the orders, I like to use CAMO for the initial stabilization. So CAMO starts for cardiac, and for cardiac you do EKG. A is access, M is morphine or pain control, and O is oxygen. You'll notice that I would type it exactly like I'm typing it because there's some shortcuts that come whenever you type it like this. So for example, whenever you confirm orders, you get EKG monitor, which is cardiac monitoring, and EKG 12 lead. We want both. We want access, and we also want to get an Acute check glucose so we can see what their point of care looks like. Maybe there's something else. Morphine, we can just give them morphine. We'll just give them some IV, one-time bolus. Oxygen, so oxygen is oxygen therapy, and then you'll see they have oxygen sat and pulse ox. So let's get an ABG so we can help triage it. Maybe they're in cardiogenic shock, and that would be helpful to know. Obviously, their pressure was okay, but always good to get a gas, and then pulse ox is important for us to see in this patient. Okay, so these are the initial ones. The other things I like to get are just other things that you would want to get in a patient. So you get CVC, CMP, someone with chest pain, you want chest x-ray. Chest pain, you also want urine drug screen. Maybe they're doing cocaine right before their chest pain kicked in. And then you can get PT-INR. We can hold off on these and just start here. Maybe a lactate would be helpful, MAG-FOS, in someone that we're concerned for cardiac things. So let's get a portable chest x-ray. Okay, urine drug screen, lactate. And you'll see it's very important to know exactly where the buttons are. It saves you seconds, but these cases, they're very fast. And sometimes you want to be able to just maximize the number of seconds you have to work it up. So here now we'll go to call me as needed. And so here we can see we got pulse ox. Okay, glucose is okay. Cardiac tachycardia and check it. Okay. Chest x-ray is clear. That's promising that it's probably not some chest thing. Always there could be a PE, something like that. But doesn't seem like it. Okay, on the EKG, we see pretty clear STEMI. And oftentimes I look for the asterisks because that will tell you if there's some abnormalities. Obviously, this entire thing is pretty abnormal. ABG, no asterisk, which means probably fine. Here, okay, maybe a slight leukocytosis, but nothing crazy. It could just be inflammatory. MAG is fine. FOS is okay. The BMP looks pretty unremarkable. Once again, you're going so fast that you want to try to look specifically for any asterisk because they'll hone in on whether there's an abnormal value or not. So we know they have a STEMI. So the first couple or set of orders I do is diagnostic. The second set is all management. And you have to go really fast here because it's all about making sure you don't miss any orders. So to get to orders, you go to order sheet. Now, we have someone with a STEMI, so let's call cardiology. Let's get a troponin, BNP. Let's get an echo. More important than the echo is probably the definitive treatment, which is the PCI, because we care about door to balloon time for this patient. If we're going to do this, we should probably get a PT, PTT. We can make them NPO. We should probably get type in screen. Anytime you're doing a procedure, I immediately get these 4 just because it'll save you time in the long run. Now, we know management, and now it's preventative things that I start thinking about, which are what may have caused this. So let's look at the lipids. Let's look at A1C. Someone like this, very low. You're never going to lose points for giving them a atorvastatin. So let's give them atorvastatin, lisinopril. We can give them. What else do we want to give them? I think these are anytime someone has a STEMI, you want to aspirin load them. You want to give them heparin. Afterwards, you'll probably want to give them clopidogrel, depending on whether the case tells you they got a stent or not, but we don't know that at the moment, so we can start here. I don't remember if they were smoked or not, but someone like this, you definitely want to make sure they're not smoking, so it's probably smoking cessation. So let's confirm these orders. So cardiology consult, oftentimes the consults, they don't say anything. They want you to drive the care, but in order to get the points or sometimes to even end the case, you have to put in the console. So you'll put an echo, PCI, PTT, and it'll never count it twice. And so it's better to just click and put in the orders. Like for example, if I did this twice, just put them in, and you won't lose points if you put in the order twice, and it won't count it twice. So it's better just click and get it in. I misspelled lisinopril. Lisinopril is spelled with an O, obviously. And then we have aspirin therapy, heparin therapy. We'll give them boluses, smoking cessation. So now the question is there anything else that we're missing? We should probably go ahead and push this through. So emergent cases, always do the call/STEMI as needed. And then in the office, I like to do with next available result. So hemoglobin, okay, nice. Good. Cardiology doesn't have anything, they never do. Okay, troponin, we see an asterisk, so great. Seems like we got an echo. The echo shows hypokinesis, poor EF. Very important. In this EKG, I didn't show this, but it was a right-sided EKG. Or it was an inferior, and so more likely right than left. So we don't want, they're fluid dependent, so we don't want to give them nitro. That could kind of tank them a little bit. Patient was taken to the cath lab, the typing screen. Okay, and now we're in the last 2 minutes to make sure we aren't doing anything wrong, but let's do this. And so in the last 2 minutes, this is when I often will put instruct, and I'll just see what orders could be good for someone like this. So for example, someone like this, they probably should do some exercise, especially limiting alcohol intake can be important. We don't know if we saw an occlusion or not, but maybe alcohol has a role to play in this. They definitely shouldn't use drugs. Smoking cessation we already did, but we'll go ahead and confirm it again. And so bunch of orders, and a lot of this is diagnose. As soon as you know the diagnosis, you want to think about how you can actually maximize your score. And I'll show you one of the best features within StudyCCS of getting these reps in, because oftentimes once you've done this a bunch, you know how to push through a case, you know what kind of needs to be done, and then it's about, can we actually get the highest score possible on the cases we feel great about? Because the worst thing is, you know the diagnosis, and you're like, what meds are you supposed to give them? Or they're having a stroke, what imaging are you supposed to get? I know the diagnosis, how do I get all the points? And so there's actually a mode, simulator mode, called Rapid Order. That one is fantastic, or SpeedOrder, really, really good. But let's go ahead and end this case, and looks like it went pretty well. So here you can see for diagnostic orders, they got troponin, CBC, CMP, PT, chest x-ray, lipid, type-in screen, echo, pulse ox, EKG, cardiac monitoring, aspirin, heparin, atorvastatin. So we have all of these, which is okay. And clopidogrel is the one that we said maybe they will need it if they got a stent or not, and we weren't sure. Once again, very low threshold to give medications, non-invasive tests, because that's how you maximize your score. Now, let me just quickly show you this. So in the SpeedOrder one, if you do this, it gives you the same case, but now you get to just work on the orders. So for example, if you pretty quickly know what's going on, you feel pretty good that, this person has an EKG, so that you'll put in all the orders like you would normally. So you'll do these, reveal diagnosis, it'll give you the diagnosis. So if from your initial set of orders that you were trying to diagnose, you couldn't get it, it'll give you the diagnosis, and then your goal is to just put in as many orders as possible. And you're just going to put them in just kind of like I did in the simulation, but maybe you'll have fewer reps. And so it'll take a little bit of time. You'll put in the orders, and then you'll hit see my results, and then you'll see your results. And it'll be very similar, but it's a much faster way. And so you get way faster at seeing a diagnosis, learning what the answer is. Seeing a diagnosis, learning what the answer is, and so then you'll get your score. So highly, highly recommend this. But if you have any questions, feel free to reach out. But just doing this consistently will get you a fantastic score on step 3. Hi there, my name is Hirsch Mulani. I'm a current NYU resident, and we're going to do another case for the CCS section of Step 3. In this case, we're going to focus on a patient who's having some shortness of breath. So let's start the case. We have a 75-year-old ED for respiratory distress, 5 days, okay. Their vitals are a little concerning, a little tachy, irregularly irregular, blood pressure is a little high, breathing pretty tachypnic and not setting super great. And then we have progressive dyspnea over the last 5 days, sleeping propped up, gasping for air, shins are twice the size, has gained weight, denies any chest pain, exercise tolerance. Okay, so sounds kind of like a acutely decompensated heart failure patient, but obviously important to do a full workup. Whenever we do this, the first thing is the physical exam always, just because that with the history will really tell us if this is what we're thinking. I always, for more urgent cases, will only do the top two of both columns. If it's a GI case, then I'll add genital and rectal, but typically only top two, bottom two. And then if it's an office case, I'll just do all of them. So let's do it, okay? So respiratory distress, accessory muscles, pretty short sentences, diaphoretic, warm to touch, so that's good. But high JVD, lots of crackles, irregularly irregular, S3, distended, lots of pitting edema. It sounds very much like acutely decompensated heart failure, but we can try to get the diagnosis pretty quickly. But obviously we want to stabilize the patient. So the acronym I use here is CAMO for cardiac access. Morphine. This patient doesn't really seem like they need pain meds, but you can always give some Tylenol. And then last one is oxygen. And for cardiac, if you write cardiac, you don't actually get this hack. But if you write EKG, then you're able to get this particular hack where it'll show up EKG monitor, which is cardiac monitoring, or tele, and then a 12 lead. So let's do that. We'll get access and AccuCheck to see if there's anything else going on there. For Tylenol, we can always just give some Tylenol. And then oxygen, you have to spell it correctly. And so let me put that in again. So for oxygen, you can get regular oxygen therapy, which this guy definitely needs, an ABG and pulse ox. So we'll have a good eye on what's kind of going on. Pulse ox, okay. So we have this. Now I want to put in all of, just because nothing has changed simulation-wise, so I want to just try to diagnose this patient. And so let's go to CBC, CMP, MAG, FOS, lactate, lactic acid, just because if this person is in cardiogenic shock, that's very different in terms of management. We also probably want to get a chest x-ray for sure. We want to get an EKG. We want to get troponin, because always could be acute on chronic heart failure. Let's get a BNP. Let's consult cardiology. Let's get an echo. This should really get majority of the things that we're doing in terms of diagnosis. And then once we're like fully confirmed this is heart failure, then we'll be able to put in all of our management, workup, so on and so forth. So MAG, we want to do MAG serum. Same with FOS serum. And you'll see that I really know where each button is. We can just get a portable because it saves you a lot of time. EKG we had already ordered, but if you put it in twice, you won't ever lose points. And usually it doesn't even let you go put it in twice if you're putting it in. So you should be totally fine. Troponin, we're putting in BNP, cardiology consult, echo. All right, so let's now fast forward. In terms of fast forwarding, I used to think big mistake was, oh, you just do the with the next available result. This is supremely slow because now you just have to keep doing this and you're wasting a lot of precious time if you just keep waiting for a result. Whereas if you do call/see me as needed, it will just, every time you get a result, you'll be able to see the result. And if that result changes management, you can then stop the timer and then put in the new orders. If it doesn't change management, then you can just keep clicking through the result. So it's way faster. And so here, okay, they have large pleural effusions, congestion, just a lot of pulmonary edema. Great. So we're feeling very confident AFib with RVR. So not only maybe they're having acutely decompensated heart failure, but maybe that stretching is leading to AFib. That's good to know because that does change a little bit. If someone's pressures are very soft, you don't want to kill their compensation. Whereas if they're AFibing with RVR, maybe that pushes us to give them a TOPE, things of that nature. At this point, whenever it gets to a blood test, I'm always looking for asterisk because that lets me know whether there's an abnormal value. So it seems like the patient is doing not super great, but not too bad. Just a little abnormal. The CBC looks fine. Mag-Phos is not too bad. Troponin, so barely up. I wouldn't call this ACS per se, and I wouldn't necessarily go down that way because this could probably be type 2. And then here we have the echo. EF is down. It's pleural effusions. Okay, so it looks very clearly like heart failure. So let's just stop it now and let's start managing it. The way we want to manage it is let's put in all the orders that we would want. So let's give some Lasix. In terms of the process of this, we probably want to just put them on GDMT. In real life, you never would, but like fully all at the same time. But this patient, just to maximize points, we should metope, prolol, lysine, pril, spirano, lactone, and Jardiance we can put in. So we have that. Anytime you have a patient with heart failure, we should do ins and outs of input and output. We should have probably a diet, which is a low sodium diet. We should probably restrict water. We should get daily weights. And I think if we do this should be majority of them. We'll see if there's anything else. So we can just give IV Lasix, metope we'll give, lisinopril we'll give, spironolactone we can give, Jardiance we'll give, input out. Okay, let's see if we can broaden the search. So we can do a 2 gram sodium diet. Let's see, is this the best we got? This might be the best we got. Okay. Not applicable. Okay, let's see if we can. Is there any water restriction order? Restrict sodium and diet. We should definitely, restrict fluid intake. So we can definitely do that. So we'll confirm both of those. Okay, and so now it's saying it doesn't like that. We already ordered this once, but we'll do this. Daily weight. Okay, that it did not like. Let's see if we can just get a weight instead. And there's our weight. Okay, so now we have a lot of the orders in. And as you can see, we're approaching the 8-minute point in which the case will end. At this point, I like to think, is there anything that we're missing? And the way I think of it is, there's symptoms that they came in with. We tossed them on oxygen. We managed all of that. Then it's diagnosis. It seems like we got all of the things we would need to know for their heart failure. We got a BNP, we got a troponin, we got the EKG, we got the chest x-ray, we got the echo. We consulted cardiology, I'm pretty sure. But in case we didn't, cardiology. Okay, cardiology. Confirm. There we go. Okay. And the other thing I like to do is to do instruct and see, is there anything preventive wise that we should have this patient be aware of? We should always make sure that the patient, I like to just things like alcohol intake, illegal drug use, all of these things are just like things that I like to click. I don't know if they actually make a difference or not. Smoking cessation, even if we don't know whether the patient smokes or not, you don't lose points for it, so it's better to have way more orders than fewer orders. But I think this is probably the majority of the orders. And so at this point, let's go ahead and end the case and see what we got. Okay. All right, let's see what we did. So here we kind of did CBC. So we have a lot of the workup stuff. And so this is all diagnostic. All of the things we would want in order to make sure we do that. And then all of the management stuff. We have all these management orders. We gave Lasix, we monitored, we gave them the proper diet, fluids, weights, cardiology. We put them on GDMT. And so I think this is a fantastic case to really understand just how to get in all of the orders and the ways to approach it. So first you want to kind of stabilize the patient, then you want to diagnose, and then you want to manage and any etiology things that could be causing it. But that's this case. Let me know if there's any other questions that you have. I'm happy to answer them. Hey there, my name is Hirsch Milani. I'm a current NYU resident, and today we're going to do another case for the CCS section of Step 3. This case is going to be a acute chest pain and shortness of breath case, and it's going to be a 10-minute case. So here we have a 38-year-old presenting to the ED with severe right-sided pleuritic chest pain and dyspnea that started 2 hours ago. She's a little bit tacky, a little tachypnic, not satting super well. Let's see what's going on. So she's a 38-year-old on OCPs, very important. Shortness of breath while just sitting at her desk. All of a sudden, that makes us feel things like pneumothorax, PE, ACS. She has also some hemoptysis, so maybe more PE than anything else. She also had a recent flight, okay, and calf pain, swelling, okay. So it seems like everything's kind of going towards like DVT leading to PE and someone on oral contraceptives. So let's go and try to actually do the physical exam and just confirm this. Physical exam is important, but all of the points come from the order, so we really want to focus there. For a physical exam in an emergent situation, I only do top 2, bottom 2. If it's abdominal pain, then I'll add genital and rectal. And if it's in the office, we have all day, then we can do a full physical exam. But this patient, I don't think really needs one. So speaking in full sentences, some dyspnea. Okay, neck veins are okay. Some decreased blush sounds. Some edema, definitely. Abdomen soft. And then tachycardic, okay. So now we have that. Let's go and actually stabilize her and then try to diagnose her. Once we have the diagnosis, then we'll focus purely on management. So for someone like this, my abbreviation is CAMO. So cardiac is the first one, and I don't like writing cardiac. I actually write EKG because it opens up a couple of things you'll see shortly. ACC for access. M is for morphine. A patient like this, morphine's fine. You can give NSAIDs, you can give Tylenol. And then the last one is oxygen. And I would write it exactly like this because if you type EKG, then you can click both of these in the same search. Similarly for ACC, you'll get access and AccuCheck, whereas if you type access, you won't get both. Morphine is just morphine. And then oxygen, you'll get all 3. So you can get oxygen therapy, so giving them oxygen. You'll do oxygen sat, like an ABG, and then oxygen sat, as in like pulse ox monitoring. So half of this is understanding the game of how the system is set up, how the orders are set up, so you can maximize that. So this is stabilizing. We haven't moved forward in time, but let's go ahead and try to diagnose while we do this. CBC, CMP. Let's get a beta HCG on a very young person. Maybe they're pregnant, increasing their risk factors. We can get a lactic acid. Let's get a PT. Let's get a PTT. We should definitely get an EKG, troponin. A BNP. Let's get a chest X-ray. We can get an echo to see if there's any right heart strain. If there is a PE. If there's lower extremity swelling, we should get Doppler. And then I think our suspicion is pretty high, so we should probably get a CTA angio. You'd get a CTPE in real life, but CTPE is just a CT angio of the chest with contrast. So let's CBC, CMP, and the goal is to really, and anytime I'm not sure whether it's serum, urine, just order both because you truly won't lose points for over ordering these insignificant kind of non-expensive, non-invasive tests. And so it's better to really get into the habit of just over ordering, and it's okay. So, and anytime you're trying to order something you've already ordered, it'll let you know. Okay, so we already ordered those. EKG we had already ordered. Troponin we have not. BNP, chest X-ray. Let's get this echo, and then Doppler lower extremities. Excellent. CT chest with contrast. So those are good. Now let's actually see if we can get it. Now in terms of timer, very important. So many people waste so much time just doing new result, and then they'll just keep doing this over and over. And you keep clicking all these buttons, and it makes it way slower. In emergent cases, I really like doing this one because each time the result's ready, it'll show up, and then you can decide if you want to keep going, or if that result changes management, now you know the diagnosis, you can tell it to stop, and you can put in more orders, and then you can push everything through at the same time. So I really prefer this. So let's initiate that. Beta HCG negative, great. Continue. No pneumo, but Hampton's hump, that's not great. Okay, a little tachycardic. Maybe some T-wave inversions. Okay, that's pretty non-specific. ABG's okay. CBC also is pretty normal. Here I'm just looking for an asterisk because oftentimes all the default values are kind of irrelevant, but if they want you to know something, then they'll put an asterisk. Here we can see, okay, no asterisk, nothing, okay, a slight troponin. Now, if the PE is leading to right heart strain, totally possible. And it does look like that's happening based on this echo. And so we'll definitely have to treat this. So, okay, we clearly have a PE here. So let's hit OK and just stop now. Because if we keep waiting for these results, we could lose points. We don't want that to happen. We want to actually start treating as fast as possible. And so for a patient like this, we should probably call the PERT team, which is like the PE, which is probably just consult pulmonary. Let's see if we can get pulmonary. Okay, brought in. Let's just do consult and see which consults we got in here. That could be helpful. Geriatric, palliative, poison psych, urology, physical. Okay, so we don't have anything here, but there's got to be a pulm consult. Let's pulmonary. Okay, pulmonary angiography, bronch, PFTs, pulmonary medicine consult. All right, there we go. And so oftentimes whenever I'm not sure, you can actually just type in kind of what you're looking for, like pulmonary artery embolectomy. I don't know if this patient's a good candidate for it. I mean, they seem like they have pretty horrible right heart strain. And so it's better to go more aggressive in patients like this. Heparin would totally make sense. We can even try TPA. The reason I feel okay giving something like TPA, even if it's not the right answer, is in a case like this, you have the flexibility. You know this patient has a large PE, and so we can go more invasive and we're less likely to lose points. Whereas if we kind of go less invasive on a case like this, there's a huge chance we lose points. So let's get heparin started as well. So we'll start some heparin therapy. So now we have all of those. Now, in terms of what else can we do for management, I think the question is like, why is this person having PEs? They could have because of medications. So we want to discontinue the OCPs. We probably want to see if they have like something like lupus or something. So let's see if we do ANA, anti-DS, anti-mitochondrial. We can get discontinue medication. Oftentimes whenever I'm not fully sure exactly what the order is, I'll search words like this and then it kind of pulls it up. Advise. Maybe they have some factor deficiency changes, like a factor V Leiden. So let's see. We got ANA. We're down to the last minute and a half. So at this point, it's really important to go somewhat quickly. So we can confirm. Okay, mitochondrial, they didn't love. Let's see if we can find it real quick here. Smooth muscle, sure. We will get ANCA, sure. I mean, this is the one we were looking for. Let's discontinue any medication, side effect counseling, that's good. Anticoagulant precaution, sure, we can do that. Contraception, not emergent, estrogen therapy. All of these are good ones to just click because advising the patient for the wrong thing, it really won't make a difference. but missing it will make you lose points. And so we want to make sure that we don't do that. Okay, it seems like it doesn't love. Okay, we already did the medication one. Okay, so it doesn't like us at all. Okay, I think our advising has come to an end. We're down to the last couple seconds. Let's make sure we, at this point, the world is our oyster. We can push through as many of these as we want. And so we got a bunch of these, and now we'll just wait for the score. We're down to our last 8 seconds. And so hopefully this is majority of the points we would kind of want. And hopefully not. Okay, fantastic. So now 93, not bad. We'll see what we missed here. So we did a lot of the diagnostic orders, factor V Leiden, grade CTA, angio, protein C and S. That would have been fantastic, actually. In a patient like this, getting protein C and S would have been really, really good to see if maybe they have some deficiencies. It seems like they would have been normal, but it's always important to do as much workup as possible, and then heparin, oxygen access, cardiac, pulm. Okay, so it seems like we did pretty good. And so whenever it comes to these cases, really, really important, you'll see it's a race against time to just get in as many orders. If you want to actually practice that part, you should not only just do the cases here. The cases, this is really good for understanding the structure of it. If you want to actually get good at the cases themselves, go to the speed order section and go to the same case. So for example, this was case 10, and do it here. And what it does is it starts out with the diagnosis hidden, and it gives you kind of the chief complaint, it gives you past medical history, so on and so forth. And then you'll put in just orders. And this is just a faster way, because the thing that takes a lot of time in these cases is just clicking everything. And so here, if you just see this, you read this, and then you start working on it. So you do CAMO, you do EKG, you do oxygen, you put in all of the various orders that you would for the actual test. You can get CBC, CMP, you can get beta HCG, CG, you can get UDS. All of these, you put them in, and then once you're done, you can hit reveal diagnosis. And if you're right, if you weren't able to pick it up from here, now I'll give you the diagnosis, and now you just keep putting in orders. And so what it does is it teaches you, okay, the first set of orders I'm going to put is going to be stabilizing and trying to diagnose, and the second set is going to be management. And so now at this point, in case if you didn't know it, you're like, okay, sure, so I need a CTA, I want this Doppler. And the other thing is it teaches you how to search in a way where you can actually find the thing you're looking for quickly. Whereas if you are constantly on test day trying to figure out what was the way that I pull up a CTPE, you're going to waste a lot of time. And so this gets you a lot of reps, and then it only gives you these 2 opportunities to put in orders. Then you hit see my results, and then it gives it to you. And so you'll see that, I just tossed in a bunch of orders, but it's a really good way to get it in all these reps very, very quickly in a way that it becomes second nature. But I think it's a great resource. Feel free to reach out if you have any questions. Hi there, my name is Hirsch Milani. I'm a current NYU resident, and now we're going to do a really great CCS case with a motor vehicle accident. And so this is one of the emergent cases that isn't cardiac, that may or may not be pulm. So here we have a young 28-year-old male brought in after a motor vehicle accident, is a little bit tachycardic, hypotensive, and a little tachypneic. So going fast, severe abdominal and flank pain versus shoulder pain with inspiration, was wearing a seatbelt. All right, so every single time I have an emergent case, you want to do top 2, bottom 2, and since this person is complaining of some abdominal pain, I would definitely get genital and rectal as well. So in this situation, you don't want to skip out on the rectal genital like you will in a lot of emergent cases. You absolutely want to get it. And so let's get this, and here we can say cool to touch. Abdomen is firm and tender. That's not great. Rectal they skipped, which is okay. And okay, so we have a firm abdomen, and so we definitely want to stabilize him, but we gotta kind of manage this. So it's one of those, like, we have no idea what's happening, but there's probably something going on. And in trauma, you'll see that they just do a lot more imaging than in a lot of other cases. And so let's also mirror that. We'll start with CAMO, so we'll get the EKG, we'll get ACC for access, we'll do M for morphine, and then O for oxygen. Once again, you want to write it exactly like this because it'll optimize your search. Half of this is just making sure that you click the right things so that you don't have to search for every little thing individually. So here, you're able to get cardiac monitoring and a 12 lead. We can get access, we can get a glucose check. Let's get the morphine. We can give IV. And then oxygen therapy, we'll give him a little bit of oxygen, maybe it helps. I mean, he's satting fine, but it's always good to check, and it's okay in a trauma to slap on some oxygen. Now, that's kind of the stabilizing orders. Even though we haven't necessarily moved forward past the physical exam, let's start some diagnosis because we have to kind of get ahead of this. So let's do CBC, CMP. We want to get a lactate. Let's get a PT, PTT. In a situation like this, oftentimes you'll get a fast exam. With the ultrasound, you'll want to do probably x-rays of a bunch of things. So let's just type in x-ray. We'll also just type in CT. Oftentimes you'll just do a full CT. I mean, we definitely want a CTAP, but we can start here. I think this is pretty good. We'll start here. We'll see if it shows anything, and we'll go from there. So we'll get CBC, CMP. Let's get a lactate. PT, PTT. Great. Both of these we already got, so we can just cancel that. Fast ultrasound, absolutely. Okay, it didn't like that. Let's see if there's another x-ray. So it doesn't like whenever you search for x-ray like that, so we'll fix that. CT, what do we want? Let's get a CT cervical spine. Make sure there's no abnormalities there. Let's get CT abdomen with contrast. Let's see, lumbar thoracic spine. Sure, we can see if there's anything else going on that may be causing pain. It seemed like the neuro exam was normal, but always good. And the problem we had was x-ray. I think it may be x-ray. You have to search with the dash. And like I'm saying, exactly. So if you search x-ray incorrectly, nothing shows up. So really important just to do this the right way and understand exactly how to do this properly. Let's get a CT chest. We can get a CT of the abdomen. I honestly, it may come back completely positive, but just good to know. Maybe we just get CT chest. I don't think anything else. I don't think the abdomen is going to show us much, but if we really want it, it's not going to really be more, it's not going to hurt our score just because it's such a benign exam for someone in a trauma. So setting okay. And you'll notice that actually whenever I did this with the clock, I always in emergent cases do this one because then all the results keep coming and you save a lot of clicks. If you do this one, you'll waste so many clicks here. But here, after each result, it gives you the option to either keep going or to stop. So for example, here with the fast exam, we see that we have some free fluid. So that doesn't sound good. And so free fluid basically means we like bought ourselves an X-lap. I'm going to go ahead and stop now. And let's, as soon as I have a order, like a result that clearly changes management, I stop it because you don't want to keep advancing because that delays care. And so we want to put in the appropriate orders. Appropriate order for someone like this is trauma surgery. And we can also put an X-lap, exploratory lap. Let's see what we get. Okay, that's the wrong one. Let's see. They're not liking this. Okay, exploratory laparotomy. Let's do that. Consult trauma. And honestly, oftentimes, if I'm not sure what's going on, okay, it's not loving us. very much. Let's see, trauma. Okay, it didn't love us. We can always consult general surgery as well. It seems like okay, there. If you just search trauma surgeon consult, it works. So we can just do that one. Oftentimes, if I don't fully know, I'll just search the word. So if it's a stroke, I'll search stroke. If it's something rheumatologic, I'll just search antibody, and you'll get a bunch of results. So similarly here, we're able to do that. So let's push these through and get some of these results. Okay, chest x-ray is fine, that's good. Okay, a little tachycardic, but otherwise fine. Gas is fine, and on these, okay, sure, that's fine. Oftentimes the consults, they don't say anything, just because the way it's set up is they want you to drive the care. But okay, CTAP was done, and okay, we have fluid, we have some fractures. Okay, CT spines are good. Let's continue. Metabolic panel, lactate is positive. I believe it. Okay, so taken for explorative laparotomy. Now someone like this with a splenic abscess, splenic bleeding, they'll probably remove a spleen. And now we're approaching the last bit where we want to put in any orders that can help us. And so oftentimes here, this is whenever I'll do advise and I'll do vaccine. And so someone that loses their spleen, there are a couple of vaccines, but we'll get there. In terms of things we want to do here, driving with the seatbelt is always good. An exercise program after, kind of like PT, OT will probably be necessary. So we'll start there. Pneumococcal vaccine, and then the other one is meningitis vaccine. You would want meningococcal, but I think meningitis is probably the best one we got. So we'll confirm that. Let's see what other labs we ordered, things that we maybe want. If someone's going, in theory, anytime someone's going to an operation, I always put in NPO. You can always try to consent. Unclear if this patient's consentable. It's an emergent procedure. They're probably not too worried. Given that it's a trauma, they're probably going to give some lactated ringers. And maybe also, given that hemoglobin was low, maybe a blood transfusion. It's pretty low risk, and in a lot of these cases where you have pretty significant emergent things going on, you can put in more invasive or bigger orders just because the patient needs it. And so now we've given them blood, we've given them fluids, we've handled their pain, we've been able to take them to the OR. I think we've done a pretty good job of both stabilizing and diagnosing, and then as soon as we got the diagnosis, we worked on management. And so I think at this point, you can probably see how it went. All right, so it seems like almost perfect. We probably missed a couple of things. Let's see what we missed. So this is a massive one. This is a absolutely massive one. Is you want to get a type-in screen for someone that is going into with any trauma, anytime you transfuse. And so that was definitely on my part, where anytime you're going to transfuse someone, you always want to order a type-in screen and then pelvic x-ray. It seems like there wouldn't have been a fracture, but if someone's coming in with pelvic, abdominal pain in a trauma, very, very low threshold for this. And then another thing you'll see at traumas is you'll place the Foley very quickly for urine output. But you'll see that so much of this is being able to think and put in the orders very quickly. So highly recommend, if you need to work on that, you actually go to the SpeedOrder Simulator. The CCS Simulator will teach you how to push through the cases, but it takes so much time to click. Whereas in the SpeedOrder one, you can just see the case. And so, for example, this is the exact same case. You have this patient, they're coming in like this. And what you do is it's broken into two parts. The first part is stabilize and diagnose. And so for someone like this, you'll do all the orders that we did. You'll do the EKG, you'll do cardiac monitoring, and then you'll get the CTAP. And once you're kind of done with your original orders, abdomen, pelvis, okay, it doesn't like us. Once you're done with your original orders, then what you do is you hit reveal diagnosis. It'll give you the diagnosis. And so now you know exactly what's going on. And once you have the diagnosis, then you put all of your management orders. And so you'll put in all your management orders, and then you'll see your results. And once you're here, it's fantastic because doing a case with the speed orders will take you maybe 3 minutes, whereas if you do the simulator, it's 10, 15 minutes. And so you're able to do way more cases, and you get really good at the instincts of, okay, with anytime I'm transfusing, I need to get this. Anytime I'm working up a cardiac thing, I want to get lipids, I want to get A1C. And so all of these things are just skills and habits that you have to develop. And so the speed order game simulator is way, way better for you to get those reps. But I hope this was helpful. If you have any questions, feel free to reach out. Hey there. In this video, I'm going to go through high yield step 3 ethics and communication. And the reason I'm talking about this is the USMLE talks about how 7 to 9% of every exam comes from the communication skills, ethics, and patient safety questions. And so this is about 8 of the 65-ish%. If you score 65% correct on the test, you basically are effectively guaranteed a pass. And so if you can nail 8% of it, you're about 15% of the way there. And so that's pretty good. And obviously this is the multiple choice section. This doesn't include the CCS stuff, which obviously we have a bunch of other videos for. So if you want to check those out later, you can. Just quick rewind. My name is Hirsch Milani. I'm an NYU resident. I create all of these videos just to streamline your studying process for step 3. I think that it's ridiculous we have to study for it, but hopefully this videos save you hours and help you get a good score. So let's jump into it. So the first thing is I have basically gone through a lot of the resources that exist from the NBME, UWorld self-assessments, and characterized all of the ethics, communication, patient safety questions. And what I've grouped them into these various categories. So you have consent, capacity, you have communication skills, you have surrogate and life and death, which like sometimes goes under consent, but the questions tend to be pretty different. Then you have confidentiality, professionalism boundaries, patient safety, and then research, legal essentials. And so it's kind of like higher yield at the top, all the way down. And here you can see all of the subcategories. All of this stuff, we're going to go into much greater detail. And so I'm just going to jump into that part because I think this is where all of the actual value is. So for the consent and capacity and autonomy, we'll call this our big section. This is probably where the majority of the questions come from. So important thing to realize in terms of key principles is capacity is like at the gate. And so a patient who understands, even if they are refusing things that could save their life, we are supposed to take their word for it. And so if they have capacity and they're understanding, they're able to explain, they're able to teach back, all of these components of capacity, that means we have to kind of go with what they say. And then no capacity is in those situations, if it's an emergency, you proceed, or if there's implied consent, or if there's a surrogate, then you go off of them. And once again, kind of how we said is capacity consists of being able to understand what's going on, weigh the options, risks, and benefits, give some reasoning, even if it's not sound reasoning, if it's consistent with their beliefs, that's meaningful. And once again, I know in residency, I've heard this a gazillion times, it's all decision specific, and so they can have capacity for one thing, but not for another. You typically don't see that, but if it's fluctuating, like in a patient with delirium, you want to reassess later if that's an option. You want to respect informed refusal, kind of as I was saying. So this is like the classic principle of autonomy. So we don't want to ever go against patient autonomy. If there's emergency and you can't consent, then you have to treat under implied consent. Or if the minor is an emergency, for example, a young child's in an accident, you treat first and you call the parents at the same time. But you don't want to wait on life-saving treatment. minors can typically consent for themselves and even for confidential care. There are some settings where this is different, and you'll see some of this in our practice questions. And then involuntary treatment only whenever capacity is lost and there's imminent danger. So let's go through some questions. So first one is, we have a 59-year-old male with pneumonia, sodium 121, who becomes drowsy and disoriented, says, sure, whatever you think, to a central line, and then asks why he's in the hospital. And the question is, why does he lack capacity? And it's not that he agreed too early. It's actually because this person clearly can't explain what's going on, why they would need it, risks and benefits. And so that's why they don't have capacity. And even though the sodium is critically low and it may explain the delirium, the capacity is the ability to assess those 4 things. And if you can't assess those 4 things, they will not have capacity. And then D and E aren't really that important. So kind of like I said, sodium's low, that's explains the delirium, but capacity is their ability to understand, appreciate, reason, and give a consistent choice. Another question we have is, you have an alert-oriented woman at 28 weeks, hemoglobin 6.4, GI bleed, who's a Jehovah's Witness, and calmly refuses transfusion knowing it may cost her and the fetus's life. Most appropriate treatment. A lot of times people get thrown off by the fetus component of this. In this situation, what the mother says goes. And so if the patient has capacity and they're refusing, then we have to respect that autonomy and we have to honor the refusal, and we can do other non-blood measures. But this is not a situation where you would get a court order or you wouldn't transfuse under implied consent or anything like that. So a court generally will not override, and so that will never be the right answer. And a competent adult may refuse treatment even if it's life-saving. For a 47-year-old male with low-risk prostate cancer who is overwhelmed and asks, what would you do? This actually, you'll see this question frequently, and you have, some of their priorities. Whenever someone asks the physician what they should do, the physician should basically never give an answer. And so, for example, here, you'll see that E answer choice is state your preferences and have them follow it. The other trap here is you completely put the onus on them, especially for someone that's overwhelmed, and you give them a bunch of information. That typically doesn't work. You want to basically help them go through what they're thinking out loud. And this is kind of what you would do for like a really good friend, right? And so here you want to explore their values and then map each option they have to those values. And so this is the way you want to do it. And really important that like almost every single test will have like, you just say your preferences, and that's basically never the answer. All right, next question. We have a 72-year-old high-speed crash, hypotensive, has intraperitoneal fluid, needs emergent lap, and no family is present, and the listed daughter is unreachable. When it comes to consent here, you just basically proceed with implied consent. And so you never want to basically like delay in trying to get consent, especially if it's life-saving. And so in this situation, we are treating under implied consent. Now we have a minor question. These are always, I know I always struggled a little bit with these early on while I was trying to really understand the concept. So a 15-year-old comes alone for STI testing after unprotected sex. She says she'll leave if her parents are told. She lives at home, is parentally supported, and not emancipated. State laws lets minors consent to STI care. So in this situation, you would provide confidential evaluation and treatment on her own consent. And so since she has the right to consent, you will allow her to consent. And this is because most states will allow minors to consent for this kind of care. And so you do not need parental consent or anything for this. Now you have a 26-year-old alert, sober, brought in after texting suicidal intent. He has a gun and plans to use it tonight, and then demands to leave. Most appropriate next step. So you have suicidal intent, and you have means, a plan, and a timeline. And so in this situation, you have to have them on an involuntary psychiatric hold. Just because you, in this situation, while you want to give haloperidol, it's actually you want to separate them from, the means of suicide. And so that's why you would basically involuntarily admit them. And the reason is they have a plan, means, timeline. And so that's why you have to do it involuntarily, even if they refuse. Okay, now communication skills. This is also very, very high yield. So anytime emotion shows up in a question stem, you want to explore and empathize before you give any advice, any test, any referral, any action. Basically, you kind of want to meet them at their emotion and just talk about their feelings. And so great answer choices are typically like, tell me more, what worries you, and basically get them to name the emotion first. And this is where oftentimes Spikes is pretty good, right? Spikes is setting, perception. So what do they understand? And then invite to basically try to figure out what they want to know. Oftentimes you'll use this with any bad news or like a cancer diagnosis, things of that nature. Then knowledge is their understanding, and then you can kind of explore the plan from there. Then you want to always use a professional interpreter, never family or children. This is also very common whenever it comes to these communication questions. The answer is always interpreter. Elicit the patient's explanatory model. And so this is kind of the perception part, where you want them to kind of explain what they understand before you say anything. And then non-adherence. Oftentimes, whenever someone isn't following a plan, you want to assess for barriers, motivational interviewing, teach back. And all of this is really important for those non-adherence questions. And we'll see it. So first, we have a 47-year-old male with worsening diabetes, looks down, says his wife filed for divorce. He's raising 2 kids. Some days I can barely get out of bed. His eyes well up. And so in this situation, you can sense some level of emotion. And so here, it's really important that you meet them where they are. You have some validating statement, and then you kind of open them up. Sometimes it'll just be a singular question where you want to be like, what worries you the most? What's bothering you the most? Stuff like that. I get that your sugars are very dangerous. Let's focus on that. Clearly, they're not ready for that. Many people get through divorce stronger. You will too. Obviously, you don't want to do this false reassurance. The D, which is, should I call your wife or family to help? Obviously not. And then, have you had thoughts of harming yourself? So this is an interesting one because this is one of those things that oftentimes whenever it comes to suicidal ideation or severe depression, you want to think of this. I think here, it's clearly not at that point. It seems like it's in the setting of this acute stressor. And while this acute stressor, you do want to assess for suicidal ideation, this is not necessarily the one. This is one where you want to first kind of hear a little bit more about what's going on. And this is why this is the best answer instead of this. We'll have one where we'll have more suicidal ideation intent, and then you'll see the difference there. Breaking bad news spikes. So whenever you have a 34-year-old woman returns for a biopsy, alone, relaxed, she says, I'm sure it's nothing. Most of these have been fine. You have privacy. So what's the best way to proceed? So as you can see here, answer A does a great job of eliciting what the patient knows. So you're clearly in a quiet, good setting to have this conversation. Now the next step is always, what does the patient understand? And so this immediately kind of tries to gauge that. It does not show cancer. You don't want to immediately jump to this. It's serious. Want to call your husband first. So this immediately changes the atmosphere. And I think it's important that you don't create that shift. You always want to elicit what they understand. Then once again, this is too far along talking about cancer. And then you're right. This is false reassurance. So you want to avoid this. And really, really, you'll notice a lot of these around false reassurance are immediately incorrect. You don't want to falsely reassure a patient. Now we have cross-cultural. So you have a patient with from Vietnam, limited English, new gastric cancer, bilingual. It says family doesn't tell the patient that they have cancer. Just tell me. He's alert and cognitively intact. Next best step. These are extremely difficult situations, and what you do in real life is oftentimes different than what you do here. But here you almost always ask through a professional interpreter, and then similarly, once you have that interpreter, you want to be able to kind of assess their understanding. And that's the most important part, because until you assess their understanding, it's really hard for you to proceed with this conversation. And so if you were to share with the daughter, you're kind of doing your patient an injustice. And so it's never this one. Having the daughter interpret is also never the right answer, because in these questions, they, for better or worse, always assume that, the family member will not disclose everything appropriately to the patient. That's why you always have the interpreter. I'm legally required to tell him, and then disclose directly is a little bit different. I mean, this is definitely much closer in terms of a right answer, but you know that with the interpreter, first you want to see how much they want to know, how much he knows of what's going on in general. And then withholding usually harms, most patients want to know. So this is too confrontational with the daughter. And if this is the only answer choice, it will never be listed as like most patients want to know or something like that. Something like most patients is never basically the right answer choice, because it's always about the patient that you're talking about. You rarely will bring in, oh, this is what most people want. Now you have behavior change and adherence. So here you have a 52-year-old, 30-pack year history, says she knows it's bad and has thought about quitting, but with work doesn't know how. She used the gum once a week. No plan to quit, best response. And so here, you want to kind of see where they're at further. And so this person knows it's bad and has at least contemplated it, right? There's pre-contemplation where they don't even acknowledge that it's bad, or they don't even think it's a problem. Here, this person's clearly contemplated it. And so now the question is, how do you help them? So a part of you wants to quit. So this is the validating component, and timing is hard. And then what would be good about quitting for you is really important, because it allows you to basically bring that conversation back to them talking. Oftentimes, the more you can have a patient talk in these conversations, just from a motivational interviewing perspective, is much better. Set a quit date and let's do this. You never want to basically be the one telling them exactly what to do. The gum failed, let's try this. You should really quit, and work stressful, so let's revisit next time. This answer choice feels tempting, and it's connected to kind of what the patient is saying. However, in these questions, you almost want to always try to make some progress with the patient. And so if you were to do this, you basically don't make progress with the patient, and that's why it's incorrect. So for surrogates, end of life, and death. So here, always important to match this to the goals. And so the way you always want to approach this is, if you know what the patient wants, great, you do that. If the patient isn't able to tell you, you go to advanced directive. And an advanced directive is always greater than that of a surrogate. Now, and a surrogate, whenever they try to provide their judgment or their ideation, what they think they should do, they should always be doing this like substitution method, where they're in the shoes of their loved one and trying to decide what they would want their loved one to do, not necessarily what they would want. And then comfort of dying, comfort for dying is very important. And so oftentimes, if you've had to help patients through this like end of life situation, you go up on the opioids, you do all these things to make sure that they're comfortable. And then very important to realize that DNR does not mean do not treat. And so if there are some things that treating them could provide relief, you would do that. And we'll get to some of those examples. So kind of like I said, valid directive is the most powerful, and it's over the family's wishes. No directive, then you go to the surrogate, and it's usually a healthcare proxy, then spouse, then adult children. Then you have in hospice, palliative, you want to titrate the meds, there's no ceiling, and then treat anything that's reversible if it would bring the patient comfort. And then brain death is only assessed off sedative medications, paralytics, and when the patient's normothermic, and then you would check brainstem reflexes. So first question, you have a patient with metastatic pancreatic cancer, air hunger, on morphine, good analgesia, SpO2, known infusion that they decline to drain, and wants to stay at home, next best step. So even though since they've declined to drain in the past, you don't want to do the thora, you don't want to stop because of the low SpO2. Frankly, whenever someone's at home like this, you don't even check in SpO2, you're treating their symptoms. adding opioid for the breathlessness or benzodiazepine for the anxiety is the correct choice, right? For air hunger, you want to treat the symptoms, not necessarily be concerned about adding more medications or hastening the death. Then you have O2 to, increasing the O2, which sure you could do, but it doesn't actually change anything, and chest x-ray wouldn't meaningfully change management, and then adding broad spectrum antibiotics wouldn't matter either. Now, whenever you have a intubated, sedated 44-year-old with a poor prognosis, declined everything, named sister as a proxy, and now would need dialysis. His separated, not divorced wife demands everything, and the sister says he wouldn't want it. On the basis of this, you would follow the directive, which we have from prior, as well as the proxy, and you would not do what the wife wants, because as we talked about, directive is first, and then here you have the proxy also in line with the directive, which is more support for that. And just because a family member would want that doesn't mean that even if that's the wife who, if the sister didn't have the HCP, technically the wife would be above it. You wouldn't do that. And so here, the correct answer choice is B. And then the other thing I want to hint on just before we get to this last one is sometimes you'll have a patient that's like clearly uncomfortable. They have like a raging UTI. And in that situation, it's okay to insert even a Foley for these kinds of patients because that would provide comfort. And so that level of treatment would be technically a minor procedure, but it would provide comfort. And so inserting a Foley or something like that could be meaningful. Usually they never ask about antibiotics questions, and antibiotics in end of life in real life is pretty complicated. And I think that's why they tend not to ask them in this situation. But if the family is on board, it's okay to also do antibiotics because you're able to treat. And so last question we have is a 29-year-old with severe TBI, evaluated for brain death. Temperature is definitely low, and then also on Fent. Pupils, nurse asked to do apnea test. Next best step is you want to technically correct the hypothermia, hypotension, and metabolic derangements first, just because fixed pupils don't confirm brain death, while you have all these co-founders. And now if you have other reasons, then you could check it, but you want to technically check all these brainstem reflexes whenever you have a lot of these derangements addressed to some degree. All right, now we have confidentiality and reporting duties. So these tend to be a little easier, and so we'll fly through this pretty quickly. So confidentiality, you basically never break it unless if it's for a couple of exceptions. You have abuse, you have threats to others, so others could get hurt. You have reportable diseases, and then like unsafe driving, which is kind of, a potential threat to others or self. So here you have never want to release information to an employer or third party without the patient's consent. Suspected child or elder care, and pay attention, it's suspected. You don't even need, complete proof of it, but if you suspect it, then you should evaluate and report it. And typically in this situation, you want to create some level of separation, but usually the first thing you want to do is report it. Credible and specific threat to an identifiable person. So if you know who is being threatened, you have a duty to warn and protect that person. For a competent adult, interpersonal violence. So here you want to assess safety and give resources. You do not want to force reporting or force them to leave that situation, because oftentimes in these situations, it's incredibly complex. And so typically based on whether they're safe and whether they want to actually accept resources, you would give these things. If they do not, then you do not force them from that situation per se. And then you have reportable communicable diseases. Here you want to notify the public health department and any partners associated. So here in a psych clinic, 41-year-old who is estranged says partner deserves to die, brought a handgun, will go to partner's home this weekend, naming him and the address. And so in this situation, you know who it is, you know a timeline. Clearly there's a lot of risk to the potential partner, and so you have to notify the victim as well as the police. Very, very important to do both of these. for a competent 19-year-old treated after a motor vehicle collision, tox screens positive for cannabis and amphetamines, discharged father who drove him and pays his insurance privately asked what it showed. The patient hasn't authorized the disclosure, and I'm assuming since it's post-motor vehicle accident, you don't have much of a mental status. In this situation, you cannot give the patient's information to the family member. It's very important that you protect the patient's confidentiality in this situation. And so even if he's paying, even if he's the father, you don't disclose it. And you wouldn't even say that it was abnormal. You just wouldn't comment on it. And then here you have a 33-year-old with latent syphilis, early latent syphilis, 2 partners, 3 months, but wants no one contacted and asks you to keep it private. Since syphilis is reportable, the health department does the notification. And so in this situation, you would report to the health department, and then the partner would be notified. But in this situation, sometimes you'll even see questions about whether you should encourage the family member to tell. And this is one of those situations where you would want to encourage the patient to tell the family member or the partner. So not only do you want to report it, if you have the option to kind of help encourage the patient to tell the partners, you should try to do that. And typically you'll see that type of question also with minors who may require something, or cannabis use, and they're unsure about how to, they don't want to tell their mother. In those situations, oftentimes in those communication questions, you'll encourage them to tell their family member or their mother or father. All right. So now professionalism and boundaries. Very, very important. So patient welfare over self-interest. Disclose errors honestly. This is very, very important. You'll definitely see a couple questions on this. And then you want to report any unsafe colleagues through the proper channels. So you disclose your own and the system's colleagues' errors to the patient with an apology and a plan. Typically, the plan is helpful. Any impaired or unsafe colleague, you want to relieve them of duty. You want to report them based on your amount of concern. You want to decline any biasing gifts or self-referral. Oftentimes with the gifts, if it's something insignificant, like, a cookie, whatever, you can accept those. Any large gifts, you definitely don't want to take, especially you'll sometimes see this for patients who have psychosis or schizophrenia or even mania. Oftentimes they'll offer some large gift. You definitely want to refuse those. In a relationship, ending a relationship with notice, reasons, referrals, and then release records despite unpaid bills. And then you have decline inappropriate antibiotics, opioid tests, and then you want to explain why. So we'll go through some examples. So a 6-year-old gets tenfold IV morphine overdose just due to a decimal error, has respiratory distress, gets naloxone, recovers in 30 minutes. Parents ask why he stopped breathing. The attending didn't order anything, didn't write the order, and worries about liability. What should you do? So in this situation, you definitely don't want to lie, saying it was a transient reaction, and you don't want to only document it and wait. You actually want to actively go out and tell the family member. So you want to tell them the error, what happened, the management, express regret, and then explain the monitoring. And the other type of question, typically, sometimes you'll get this type of question as one of those multi-part questions. So you may get this. And then the next question is, what should you do? And so sometimes they'll say root cause, all this stuff. But typically, whenever it comes to solutions to solve these problems, it loves the electronic ones that are EHR based. So if it's an EHR alert that the dose is greater than the general range, that is almost always the right answer. So highly recommend whenever you get that question to select that one. So for boundaries and gifts, so you have a 29-year-old, you've been treating for 8 months, she's developed feelings, hands you a gift, and then ask you to dinner this weekend, clinically stable. So in this situation, you definitely want to decline not just the gift, but also the invitation. You want to explain why it's appropriate, and then you can continue her care. Sometimes you will even see the answer choice to transfer her care. And basically, in these situations, it is completely inappropriate to accept care with anyone that you treated at any point. So that is basically never the answer choice. And then if you accept the gift to avoid embarrassment, that is also never the right answer. And immediately terminating the relationship also isn't necessarily the right answer, because if you decline this offer and they want to continue care, that's okay. But it's really important that you don't accept any of the gifts or transfer the care immediately. There are some situations where you will have to transfer the care, but this is not one of those conflicts of interest. So urologist owns an IMRT center, recommends IMRT done at that center for low risk prostate. The patient asks what to do. So in this situation, technically it's okay for the urologist to own the center. However, they have to disclose their ownership. This is really, really important. And so one of the best things they can do is present all the options neutrally, but also offer independent radiation oncologist or someone else to basically provide suggestions if that's helpful. Obviously, you don't want to just refer to the center without mentioning the financial interest. You don't want to just avoid it. You don't want to mention ownership only because they asked. You want to make sure that you disclose the ownership no matter what. So now you have a resident who notices an attending anesthesiologist with slurred speech, smells of alcohol, and then a mislabeled syringe 3 times a month. No patients harmed. Co-resident suggests quietly covering for him. Best action. So clearly this is not just a one-time thing. This has happened multiple times. And just because a patient hasn't been harmed yet doesn't mean you shouldn't report it yet. You should go ahead and report it early. So you basically always go up the chain. So you would report it to the chair. The other thing that's really important here is it talks about confronting them. Typically the confrontation or talking to them in private, that is usually done in situations where you have less of this power dynamic. You'll notice that here you have a resident and an attending anesthesiologist. And so basically you want to make sure that in these situations, you just go up the chain, because if you were to try to, confront and all, it may not go well. And so typically you can just go up the chain. New patient demands alprazolam refill, brings no records, won't sign a release, gets irritable, wants a disability letter, no basis, he's leaving town in 2 days. So basically with all of this stuff, you just decline and you schedule a follow-up. It's always a tough situation in real life, but here you never want to give these kinds of things, especially if you have a patient that's resistant to a lot of things, but you want to make sure that they have follow-up, because they probably, if they're not getting it from you, they'll get it from someone else. So you don't want to just decline all care, but you want to definitely not give them the prescription. You also want to make sure that you are offering this evaluation, right? Like all of these things, just because they aren't meeting you where you think they need, you need to continue to take care of them. And so the evaluation, a follow-up, all of this is good. If you just refuse everything, then once again, discourages their care. All right. So now we have patient safety and systems-based. So this is kind of what I was talking about when it comes to systems failures. And so how you actually approach these. So you always want to assume that errors are systems-based, typically never blame the person. And so typically you want to have systems to report. You want to do root cause analysis to see what's causing the problem, and then you want to standardize. I think standardization, any answer choice that kind of goes towards protocols and some way to make sure that everyone's doing the same thing is very, very good. So after an error, you always want to report it, and then you want to do a root cause analysis. You want to fix the process. You want to report even near misses, even if no one was harmed, to prevent reoccurrence with systems tools. This is very, very important. And then also like standardized order sets, checklists, timeouts. All of these protocols are really good ways to address things. And then stopping the line. So whenever you have key information that's missing, especially in operations and all, making sure everyone feels like they have the culture and the space to be able to speak up is really important. And so always choose the structural fix over just reminding the staff or whatever. You want to make sure that every answer choice you do here feels like it's making the hospital system better, right? And so you want to think almost like a hospital admin for these. So first question. So over 8 weeks, 3 different nurses on 3 shifts give 10-fold heparin overdose, no serious harm, best next step. So here you have written warnings to the 3 nurses. Okay. So clearly if it's multiple nurses, it's a systems problem, not just a nurse problem. So that's not it. Repeat an online safety module. Safety modules don't work. It's never the right answer. A root cause analysis and segregate the lookalike vials. So oftentimes you'll either see one of these answer choices. And so you can consider either one of these, right? Because they're both systems oriented. Typically you want to do the root cause analysis, which will help you realize that this is the reason. And that's when you'll separate it. And then suspend the most recent nurse. That doesn't make sense. And then similarly, an independent nurse check for every med would be ridiculous. Oftentimes they'll have tests like these. Because it sounds like, that's good. That's what they do for wastage and stuff. But whenever you think about actual workload and stuff, it's not realistic. And so sometimes they'll have these answer choices that sound like a good answer, but they're not realistic. And so it's your job to actually know it's not realistic and that it's not a good option. So handoffs. So you have a patient on a heparin drip, move to the floor with a rushed verbal sign out. The overnight team, unaware that she's anticoagulated, over his I am antiemetic, gets a large hematoma. And then best way to prevent these kinds of events. So typically a standardized handoff tool. So the reason this is so good is because it's standardized. Like that is the magic word that they love here. It's not about the person. And you can often almost times just go through all of the single things that are about like, this person made a mistake, you basically marked it out. Keep the day team until all overnight orders are in. That's not the best answer choice, and it's not necessarily one that will, be reliable moving forward and necessarily prevent this kind of thing, because people can just rush these. Make nurses call the attending before any injection. Once again, one of those answer choices that sounds fine but isn't realistic. And older woman discharged after a COPD flare returns confused and tumultuous. Home metope was never charted, and she was discharged and got new tramadol plus resumed sertraline. Which of the following prevents this? And so, whenever you have this, clearly you see there is a medication problem, and so this is all like a med reconciliation problem. And so, very important that med reconciliations, checklist, both of these things are things that anytime there's an error like this, they really love those answer choices. Obviously, a pharmacology lecture for the residents wouldn't change anything. Electronic prescribing of the meds wouldn't fix this. Asking the patient to bring a med list is putting the onus on the patient, and you never want to put the onus on the patient whenever there's an error. And then a 48-hour post-discharge call. This is maybe helpful, but once again, it wouldn't necessarily catch the error as quickly as you would like, and adds a lot more onus. Now, a nurse catches a tenfold chemo overdose before it reaches the patient, files a voluntary report, no harm, just a culture. The institution in this situation should thank her and analyze the near miss to fix the ordering system. So an ordering system here is like the way that it's ordered, so a notification, things of that nature. And so, obviously, A doesn't make sense, C doesn't make sense, E doesn't make sense, D doesn't make sense. Now, oftentimes, you'll also sometimes see near misses and whether they should be reported to the patient. Typically, you don't report a near miss to the patient. It's an institutional thing to fix, not necessarily to report to the patient. So it's if the patient gets a wrong medication, even if there's no harm, you would report that error to the patient. However, if right before the patient is about to get the wrong medication, they don't get it, that would not be reported to the patient. And lastly, we have research and legal essentials. So a lot of this stuff is sometimes you'll have IRB questions, you'll have legal questions, things of that nature. These are the lowest yield, and so you won't see these as often, but I just wanted to kind of go through some of these. So you need IRB approval. You need to make sure that whenever possible you can randomize. You want to make sure that you stop any trial that is either harmful or futile, and so you don't want to do that. Vulnerable populations need to have protections, and so very important that you're not enrolling vulnerable populations into studies whenever they can't understand it, and you want to disclose any financial conflicts, any medical screenings, stabilization is required. And so for anyone in the ED, regardless of their ability to pay, And then malpractice, you want to always make sure that you're aware of the duty, the breach, the direct cause, and then the damages. These are typically the 4 Ds. So for an IRB, for an RCT, for a new anticoagulant versus warfarin for AFib, in the pre-planned interim analysis shows that the new drug clearly cuts strokes with no bleeding, crossing the efficiency threshold boundary. So basically this means that this new medication is clearly much better than the prior. By continuing the prior or continuing the trial, even if the fellow wants, that's actually harmful to all the patients on warfarin, and you should actually stop early for efficacy and offer the better drug to all of the participants. And then obviously you wouldn't want to keep enrolling, you wouldn't want to unblind the investigators, you wouldn't add a third arm, you wouldn't switch, because once you've kind of seen this clear benefit, you want to make sure that you have everyone. And then you have an uninsured person walks into ED, crushing chest pain, asks for insurance and deposit, but before he's seen, but the ECG then shows that there's a STEMI. So in this situation, you screen and you stabilize, and then you get them the cath, and then you worry basically about the money after. And so in this situation, you always provide care for the patient. And so overall, these are the main things that you will see on the exam. And I'm sure that there'll be other questions that we didn't hit on, but I really wanted to hit on the highest yield ones and then the various variations that in which they'll show up. If you want access to this sheet and all of our other cheat sheets, want access to our CCS cases or speed, everything is included in the CCS package. And so everything's complimentary in there. So you can just check out the website and do that. There's a discount code for 20% in the comments as well. So happy studying. I hope this is helpful. Hey there, in this video, I'm going to go through high yield USMLE Step 3 biostats. And whenever I say high yield, I truly mean high yield. What I did is I went through all of the free 137s, all the NBMEs that I did whenever I studied for Step 3, and basically categorized each type of biostats question. And based on the categories, these are the ones that were the highest yield. And so this is not comprehensive, but the idea is after this video, you shouldn't have to think about the formulas. It should feel very intuitive. And so that's my big picture goal. Hopefully by the end, you'll be able to actually look forward to these questions rather than dread them and see a lot of these easy points. Just for some background, my name is Harsh Mulani. I'm an NYU neurology resident. I actually also have an MPH. And so I've been doing a lot of biostats in my life. And so my goal is to make it so that all of this is very intuitive. So let's jump into it. So first, I'm going to do this just as a question, and then we'll kind of get into all the tactics, and it'll flow very seamlessly. So the first thing I want you to just learn whenever you see these questions is it says a bunch of words, and your whole idea is how can you actually make sense of the numbers here. And so you'll quickly realize is whenever you're reading these questions, you're not actually trying to understand what's going on. And frankly, a lot of it doesn't matter. You just want to understand what the main numbers are so you can make your 2x2 table, because that is king. So whenever you actually look at it, you have a new rapid antigen test and it's being evaluated against PCR. This immediately lets you know that now you're going to compare it. And so you're obviously going to be testing how good the rapid antigen test is. And the reference standard is 500 people. And so this means that for 500 people, the PCR will confirm that 100 of them have the virus, which means 400 of them don't have the virus. So that's helpful. And now the rapid antigen test is positive in 80 of them. And so whenever you see this, you're immediately going to start drawing your 2x2 table. And a lot of people even struggle to figure out where the test goes, where the disease goes. The way I always think about this is the truth is at the top. So T for truth, T for top. And so whether they have the disease or not always goes at the top. So you have the positive here and the negative here. And so these are the people that absolutely have the disease. These are the people that don't. And then for your test, you always have the positive on top and negative on bottom. So here, when they say 500 people were in the total study, that means you have 500 total people here. And so whenever you fill it in, you'll get 500 people here. Now, you know that if 100 of them are positive, that means the others are negative. So that means there are 100 people with the disease and 400 that don't have the disease. And so this gets you this. And now here, luckily for you, it tells you that the antigen test was positive in 80 of them. So you know it was positive in 80. And so now with the 100 and the 80, you can fill in the 20. So now you know that 80% of them had a positive antigen test based on this. And so here you also know that the rapid antigen test said it was positive in 40 of the people where the PCR was negative. And so antigen test here was 40, and so you'll fill in 40 here. And now you'll have this number, this number, this number, this number. And so then you're only missing these three. Luckily for you, it's easy to get the total here. And so you get the 120. And then similarly, you'll now be able, since you know this is 20, this is 40, you can actually calculate this. So from 40 minus 400, you get 360, and then this will give you your 380. So now you know all of the people who have a positive PCR, a positive antigen test, a negative PCR, and a negative antigen test. And so at this point, we come to the actual questions. So once you have your chart filled, this should feel instant. And the good news is once you start thinking about this, you'll actually not have to think about it much at all. And so whenever I think about this, immediately I'm thinking sensitivity is this number divided by this number. That's the only thing I'm thinking about. I don't think about anything else, because if your chart is set up thinking about true positive, false negatives, the sum of these, it doesn't matter. All you want to know is how good is your test. The only way to know how good your test is you have the number of people that it said it was positive out of the total number of people that had the disease. So as soon as you know this, and so this means that if you were to read this question, and in the question, it said the PCR said 100 people had it, and the rapid antigen test had 80, immediately you should be able to get the sensitivity. You don't even need the rest of it. And so you can get that 80% instantly. Now, if the exam asked for the sensitivity, which oftentimes it will, right? If it asked you this question, you'd get it instantly. You don't even actually need much of the table. Now, for the specificity, it's a little harder because at this point, specificity is this number divided by this number. So true negatives minus the sum of all of the negatives here. And so whenever you have this means you would have had to calculate this number. Only way to get this number is to realize this is 40 here. You have the 40, and then you start adding, subtracting, dividing in order to get the specificity. And so all you have to know is this number divided by this number. I frankly just think about it as a box. So whenever, now conceptually, let's understand this. For a test to be sensitive, that means if you're going to test it, will it be positive? So sensitive is looking for, is it going to be positive? And so here, you know that the rapid antigen test, you have 80 over 100. That's the sensitivity. That's how sensitive it is to actually know whether someone has disease. Specificity, the whole goal about specificity is this only for this test? And that's the way I think about it is this only for this test? If you think about, oh, how does sensitivity connect to, the true positives, false negatives, all of that's too confusing. Is this rapid antigen test, is it just for this test? And so if you look at the people that it says it's negative for, out of all the people, how often is that correct? And so now you have the specificity. Positive predictive value is actually one of the most meaningful things in medicine, because this is actually a measure of how good the test is. It has very little to do with the disease. It purely has to do with how good the test is. And so oftentimes you'll hear that South Asians have a very high positive predictive value for if they were to have chest pain, for it to be ACS. And so similarly here, if 2/3 of the time is correct, that's a pretty garbage test, right? Like a good test would be one that is closer to 90, 100. And the reason I say that is because 50-50 is if a test is good or bad whenever you're in positive negatives, right? If you had a pregnancy test that was only correct 50% of the time, you wouldn't trust it. Similarly here, you want to have a test that is as high as possible. And so positive predictive value is this number divided by this number. And similarly, negative predictive value is this number divided by this number. And so the reason the extended chart is so important, and the reason I think it's messed up that, so many people only make this base chart, is because the extended chart allows you to actually calculate all of these without having to do addition of this, addition of that. Sure, you get it to get the numbers, but once you have the numbers, it should be very clean and easy. Now we have the ROC curves. these are supremely easy. And so the whole idea of this is basically you want a good test maximizes the area under the curve. AUC is area under the curve. So if you have a test where here you have the true positive rate and the false positive rate. So a good test is obviously something with a very high true positive rate. So as high on the x-axis as possible, so as high as the curve can go here, and a low false positive rate, so as small as it can go here. And so this simply teaches you that the curve that has almost the whole box covered, where it comes as close to this corner as possible, is the best answer. So if it asks you for the best test, it will always be the curve that is as close to this corner as possible. And oftentimes it is instant. You'll see the question, they'll say, what's the best test? You'll pick the answer A or E, whichever one's closest to here, and you'll get the point. The reason here you can see that this test has no predictive value is because a test that has a 50-50 chance, a coin toss on whether it gives you the right result or not, is a useless test. And so the closer it gets to this line is the likelihood that it's up to chance, and then you'll never see a curve that curves under here. And so basically all you have to do is look at the corner and see which line brings you closer to this corner. And I want to teach you that if you can do one 2x2, you can do any 2x2. For example, now we're going into study design, and this always trips up so many people, but my goal is to make this really simple for you. So if you have an RCT where you have 200 people with a prior MI, and they're going to receive a new drug and a placebo. So immediately you know you're in RCT and you have 200 total people, you have 200 people getting the new drug and 200 people getting the placebo. So that means you have 400 total people. You can start setting it up. So once again, you're going to focus on the main words, and then you're going to look at the follow-up, and you can see 15 patients in the drug group and 30 patients in the placebo group ended up having the MI. So whenever you set this up, I want you to draw it out right now. So if you can draw it out, pause the video and draw it out. What are you going to put at the top? What are you going to put on the side? So before I show you the answer, the truth is always at the top. And so the truth here is the MIs. Do they actually have MIs? And so those will go at the top. And then the drug or the test that you're doing is going to be on the side. And so that means that you'll have 200 people all the way here, 200 people all the way here. You have the MI here, and then you have the drug here. So like it says you have 15 people that ended up having an MI in the drug group and 30 people in the placebo group, which is the negative. Since you know this number, you can immediately get this number because there are 200. So this gets you 185 and this gets you 170. Now, sometimes what I'll do is I'll just build this part, and based on what the question is, I will add this next part or not. Because if you've already built this part of the table, if it's asking about the risk and things like that, a lot of this you can get away with without doing too much. So first, let's talk about the risk of having an MI on this drug. Oftentimes, if you start doing addition, like I said, with A plus B, all of this stuff, it becomes too complicated and it feels like, oh, did I add this? Did I not? Here, since you already know the total, the risk of the drug is really simple, right? You just divide the total number of people that have the MI out of the total people in the group. And so you have 15,200, that gets you the 7.5. Then for placebo, you have same thing. You have number of people that had it on it and the number of people that were total in the group. So 30. And so the risk reduction, whenever you're thinking about this, should feel very, very fast, right? How quickly are you able to address this problem? So whenever you're doing this, this is half the battle. Now the next four are basically a significant component of high yield material for biostats. So whenever you look at this, you want to look at the relative risk. And so what is the chances of someone in the experimental group versus the control group? So here you have 7.5 and 15. So the risk reduction is 0.5, which means that if you were to be in the drug group, you are 50% less likely to have an MI than someone in the placebo. That sounds fantastic, right? So this is 0.5 or 50%. Now, whenever you think about relative risk reduction, that is just 1 minus the answer. So here, we're lucky that the answer ended up being 50% again, right? Because if you just do 1 minus the risk reduction. So for example, if you were to change this and it was just 0.3, right? You had a 30% less likelihood of having an MI in the new drug group versus the placebo. The relative risk reduction would be 70%. So it's a very simple formula, but you want to just think about it as in, if the chances of having it were 30, the relative reduction, how much it dropped my risk. Because imagine before you had a 100% chance of risk. What you should always think about is this 1 is actually a 100% chance. So if I'm in the placebo group, I have a 100% chance risk of having an MI. If I were to take the new medication, it would drop my risk by 30. My relative risk reduction would be 0.7 or 70%. And then the absolute risk reduction is always the easiest because it's quite literally just this number minus this number. And so this is the absolute risk reduction, and this is the 7.5. And number needed to treat is super duper easy because all you have to do is to take 1 and divide it by this number. So that means if there's an 8%, I'm going to round this up to 8% just for simple math. If you have an 8% chance of not having a MI on this new medication, that means if we'd had 14 more people, then we would be able to prevent an MI. And this number actually in scientific studies is so important because this lets you know the amount of people this medication will help in the future from avoiding the outcome. And so I would spend time here. We have a bunch of these questions in the StudyCCS platform. So if you're doing some cases and you're bored and you need to work on your biostats, you can do those questions and it'll help you a lot because these are super, super high yield. And now the clinical study. So the reason I wanted to explain this is because from now you know how to do a 2x2 table. You see a 2x2 table, it feels instinctual. This is supremely important and everyone forgets this, learns it, forgets it, learns it. And then whenever it shows up on test day, they're not sure. And so my goal is in the next couple minutes so that to teach you this in a way where you never forget it and it feels instinctive. Okay. So clinical trial. If you're doing a clinical trial, that means, especially a randomized clinical trial, that means you're randomizing them to a treatment and a control. So just like here, you saw that they're going to receive. This means that you're going to give them something. So all clinical trials, it will always have something like you put them into 2 groups, but it's not that you siphoned it up based on what they had. It's some of them are going to get this, other people are going to get this, you're going to get the outcome. Great. Now for a prospective cohort study and a retrospective cohort study, I want you to understand this. People really struggle. Prospective is a little easier to understand, right? Because this means that these people have exposure to something, right? Maybe it's this neighborhood versus another neighborhood, or smoking versus not smoking, right? So they have exposure to an actual stimuli, something, and then you're going to follow them forward. And so then you're going to see disease. I always like to think of smoking and lung cancer because it's very easy for me, right? We're going to look at these people that smoke and these people that don't smoke, and we will see if they develop lung cancer in the future. Similarly, as a medical student, oftentimes we would do these chart reviews and we wanted to see what happened based on data we already had, because retrospective cohort, way faster to do than waiting the months that it would take for a prospective cohort. And so what you can do is you go into the chart and you look at a note. So retrospective cohort means that we're going to look back. Okay. So now imagine we're just shifting time and we're going to look back on people 3 years ago and see if in their notes it said that they were a smoker. So you're going to still look at exposure. You're going to see if they were a smoker. And so you're going to look at a bunch of notes from 3 years ago, and then you're going to move forward, and then you're going to see what percent of disease happened. So what percent of those people now have lung cancer? And so what this does is now you can actually see the rate at which it happened. And so this is really, really important, and you'll see the importance whenever you get to cross-sectional. And so you're just going back, you're looking at a note from 3 years ago, and now do they have lung cancer? So that's retrospective cohort. This is so commonly confused with case control, But the simplest way to understand case control is you don't know the exposures yet. You are actually looking at their notes today and you're saying, hey, this person has cancer. And now I'm going to look back on their own notes to see what other exposures they had. Maybe they smoked. Maybe they had diabetes. Maybe they had hypertension. Maybe they took this medication. And you're going to look back for exposure. And so with retrospective cohort, you're going back in time first. You're going to find what they were exposed to and see if they have the disease. And then the case control, you know they have the disease. And so you're going to actually look back in their notes and you're going to see the different things that they could have had exposure to. And then cross-sectional is one of the best and easiest because it means we have this group of patients right now. I need to crank out a paper. What can I figure out? And so oftentimes you'll do prevalence here because prevalence is what percent of people have something, right? It can be what percent of my patients are left-handed. And you can calculate the prevalence of people that are left-handed, or you can look at the percent of my patients that smoke, the percent of my patients that have lung cancer. And you can just look at this single snapshot in time. And so to really hammer this home, we're just going to do some questions. So investigators randomly assign. So as soon as you're assigning people to a new medication, you're immediately thinking RCT. And so as soon as you hear assign, it's going to be moving forward. You're thinking RCT. Now you have investigators enroll 2,000 healthy adults and classify each as a smoker or a non-smoker and follow them forward for 15 years to compare the incidence of lung cancer. So you have people that you know either are smokers or non-smokers and you're moving them forward. So this is a prospective cohort study. The interesting thing is now you can see the rates of lung cancer, right? What percent of these will develop lung cancer? So it's not what percent have lung cancer right now as you would have in a case control. Sorry, in a cross-sectional. It's actually what will develop. Now, using employment records from the 1990s, so we're already back in time. You identify people who were not exposed to asbestos. So you're looking back in time and they were exposed and not exposed to asbestos. And now you're going to look at their chart today to see if they have mesothelioma. So this is clearly a retrospective cohort study. You saw their exposure to see if they developed the disease. And then here you have 150 with pancreatic cancer. So people that have pancreatic cancer right now, and then 150 people that don't have it. So imagine you are a oncologist. You have a group of 300 patients, and you know 150 of them have pancreatic, and 150 have other stuff. Maybe they have other stuff, and you expect all that to normalize, but 150 have pancreatic cancer, the others don't. Now let's just see which percent of them use smokeless tobacco in the past. And so now you're going to go back and look at the past data. And so this is a case control study. And then here you have a single survey. Oftentimes whenever you have a single survey at this point right now to measure both obesity and knee osteoarthritis in 3,000 adults, this is a cross-sectional study. And so hopefully this was helpful. This is just the beginning because there are other topics. But if you can just nail these questions, I guarantee you, you will know 80% of all of the different biostats that will show up on step 3. And so the goal is in this video to really just squeeze as much of it as possible so that you just know the exact topics. You can keep watching this. And if you need practice, you can just use it at StudyCCS. We have a discount code in the description below. Hi there. In this video, I'm going to go through high yield risk factors for step 3. Some quick background. My name is Harsh Mulani. I'm a NYU resident. My goal with these videos is just to cut short as much of your step 3 studying as possible. And so hopefully this helps. In this video, I'm going to go through all of these systems as quickly as possible. And so it's a good video to pause as you need, come back to it, watch as many times as you need. And all of these individual sections are also going to be posted separately if you just want to watch a particular section. All right, cardiovascular. The most important modifiable risk factor for CAD is smoking. Most common cause of death of lupus in later life is ischemic heart disease or advanced coronary artery disease. Most important prognostic factor for coronary artery disease is LV function. Most common cause of death in chronic hypertension
is acute MI. The most common complication of chronic hypertension is LVH. The most common cause of arrhythmia in a STEMI is PVCs. Most common cause of death in acromegaly is heart failure. The most important disease associated with central sleep apnea is heart failure. Patient admitted in the US most likely has CHF. Leading risk factor for AFib overall is hypertension and increasing age. Leading structural cause or valvular cause of AFib is mitral stenosis. Most common arrhythmia and hyperthyroidism is AFib. Most common cause of death in CKD is cardiovascular arrhythmia and then infection. Leading risk factors for mitral stenosis is rheumatic fever. Most important physical exam finding in AS is pulsus parvis tardis. Most common valvular abnormality in the elderly, AS. Most common valvular complication of Marfan's is mitral valve prolapse. Leading risk factor for mitral regurgitation is also mitral valve prolapse. Leading risk factor for development of an abdominal aortic aneurysm or a AAA is smoking. Greatest predisposing factor to rupture of an AAA is the diameter of the aneurysm. Leading risk factor for stroke and AD is hypertension. Most important predictor of survival in aortic coarctation is age at the defect repair. Most common cause of death in Ehlers-Danlos syndrome is aortic dissection. Most common complication of an LA thrombus is embolization. Hypertrophic cardiomyopathy. The most common sarcomere gene mutations are on the 14th chromosome is the most common one. This is the MYH7. Then there's also the MYBPC3 on chromosome 11, but the chromosome 14 one is the classic answer. EKG findings in cardiac amyloid, low voltage. Most common cause of death in lupus early in life is due to infection. Most common cardiac finding in lupus is fibrinous pericarditis. Most common cause of drug-induced lupus. Most common cause of death in a kidney transplant patient, cardiovascular disease. Most common cause of death in autosomal dominant polycystic kidney disease, cardiovascular disease. Subarachnoid hemorrhage is the classic one that you hear, but it's not the most common cause of death. Most common complication in a patient with a very low BMI, ventricular arrhythmia from hypokalemia. Also, we get a lot of questions about all of these cheat sheets and different study guides that I make. Everything's included, complimentary within just StudyCCS. So the goal is to have the best CCS cases while also being able to access all these cheat sheets. Everything's included for in the package. Pulmonary and crit care. Most important goal in COPD management is smoking cessation. Most common infectious precipitant in an acute COPD exacerbation is H-flu. Leading risk factor for obstructive sleep apnea, obesity. Most common cause of CAP is strep pneumonia. Most common complication of influenza is primary just flu pneumonia or a secondary bacterial superinfection. Most common cause of a pneumothorax in a patient with HIV, pneumocystis pneumonia. Most common cancer associated with asbestos exposure, bronchogenic carcinoma. Mesothelioma has no relation to smoking. Just putting that out there. Pneumoconiosis that increases TB risk, silicosis. Most common cause of death in systemic sclerosis, respiratory/pulmonary failure. Most common anterior mediastinal mass, thymoma. Most common middle mediastinal mass is a lymphadenopathy. Most common posterior mediastinal mass is actually a neurogenic tumor or schwannoma. Most important factor in preventing ventilator-induced lung injury is low tidal volumes. And so this is decreasing the ventilation. 3 complications of oxygen therapy in a neonate: bronchopulmonary dysplasia, retinopathy of prematurity, and intraventricular hemorrhage. Most common cause of death in the ICU: septic shock. Nausea or vomiting. Do not place them on a bi-level or continuous positive pressure just because of aspiration risk. Most common complication of tetanus: pneumonia and cardiac arrest. GI. Leading factors of esophageal carcinoma: Barrett's esophagus. Most likely clinical complication of Barrett's esophagus: esophageal ulcers with strictures. Most common infectious cause of odynophagia: Candida albicans. Biggest risk factor for iron deficiency anemia in a patient with H. pylori is peptic ulcer disease. Most likely vessel in a bleeding gastric ulcer is the left gastric artery. Most likely vessel in a bleeding duodenal ulcer is the gastroduodenal artery. Most important prognostic factor in mesenteric ischemia: bowel infarction. Most important prognostic factor for outcome of colon cancer treatment: stage at the diagnosis. Most common complication of Hirschsprung's disease: death from enterocolitis leading to toxic megacolon. Most serious complication of UC: toxic megacolon. Most common complication of diverticulosis: diverticulitis. Most common complication of Meckel's diverticulum: bleeding. Most common complication of appendicitis: periappendiceal abscess. Most common cause of osmotic diarrhea is lactase deficiency. Most likely cause of treatment failure on a gluten-free diet in patients with celiac disease is non-adherence. Most important oncologic association in long-standing celiac disease: small bowel lymphoma. Leading risk factor for cholangiocarcinoma is PSC, primary sclerosing cholangitis. Most common cause of esophageal varices: portal hypertension. Most common cause of fatty change in the liver: chronic alcoholism. Most common cause of death in cirrhosis: rupture of esophageal varices. Most common cause of cirrhosis in children is alpha-1 antitrypsin deficiency. Leading risk factor for hepatic adenoma: OCP use. Leading risk factor for hepatic angiosarcoma: vinyl chloride exposure. Leading risk factor for cholangiocarcinoma in the US is PSC. Most likely cause of abnormal liver function tests on routine labs is non-alcoholic fatty liver disease. Most common cause of acute pancreatitis in the US: gallstones. Most common cause of chronic pancreatitis: alcoholism. Leading risk factor for pancreatic cancer: smoking. Most important therapeutic step in acute pancreatitis: IV fluids. Complication of acute pancreatitis at 1 to 2 weeks: pancreatic pseudocyst. Leading risk factor for chronic pancreatitis in a child: cystic fibrosis. Leading risk factor for pancreatic adenocarcinoma: smoking. Most common pancreatic neuroendocrine tumor in men type 1: gastronoma. Most common complication of cholelithiasis: biliary colic. Most important complication of peritoneal dialysis: peritonitis. Renal and GU. Most common cause of nephrotic syndrome in African Americans: FSGS. Most common cause of nephrotic syndrome in Caucasians: membranous nephropathy. Most common cause of nephrotic syndrome in children: minimal change disease. Most likely renal complication of aminoglycosides: ATN. Most likely renal complication of sickle cell disease: painless hematuria. This is secondary to papillary necrosis. Most likely obstruction in nephrolithiasis: ureter or uretovesical junction. Most common complication of an upper UTI: hydronephrosis. Most common complication of BPH, obstructive uropathy. Most common cause of a UTI, E. coli. Most common cause of sepsis in a hospitalized patient is an indwelling catheter, most commonly due to E. coli. A diabetic with pyelonephritis not responding to antibiotics get a CT to rule out a perinephric abscess. Most important finding in diagnosing renal artery stenosis is an abdominal bruit. Most likely mechanism of weight gain in a hospitalized patient is increased total body sodium, which then increases the water and the hyponatremia with increased urine osmolality, SIADH, or ectopic ADH production. Leading risk factor for hyperphosphatemia, chronic renal failure. Leading risk factor for bladder cancer, smoking. Leading risk factor for ED, cardiovascular disease. Most common cause of impotence over age 50 is vascular insufficiency. Most likely complication of von Hippel-Lindau disease is bilateral renal cell carcinoma. Most common complication of systemic amyloidosis is renal failure. Most likely organ to develop a complication in lupus is the kidney. Most serious complication of extrarenal autosomal dominant polycystic kidney disease is rupture of an intracranial berry aneurysm. Lupus antibody associated with kidney disease is the anti-double-stranded DNA antibody. Most common cause of death in cervical cancer is renal failure from ureteral obstruction. Leading risk factor for end-stage renal disease in the U.S. is diabetes. Most common cause of diabetes insipidus is lithium. HEMONC. Most important prognostic factor in cancer is staging. So, tumor, node, mets will determine staging. Most common mutation overall given rise to malignancy, P53. Most likely reproductive complication of systemic chemotherapy, hypogonadism. Most common complication of a terminal disseminated malignancy, cachexia. Hospitalized patient with hyperkalemia. Hospitalized patient with hypercalcemia, bones grown psychiatric overtones, malignancy. Leading risk factor for esophageal adenocarcinoma is Barrett's esophagus, secondary to GERD. Leading risk factor for squamous cell carcinoma of the skin is sun exposure. Leading risk factor for ovarian cancer is family history of ovarian cancer. Leading risk factor for prostate and breast cancer is age. Leading risk factor for papillary thyroid cancer is prior chest or neck radiation. Leading risk factor for endometrial cancer is unopposed estrogen, leading to endometrial hyperplasia. Leading risk factor for prostate cancer is age. Leading risk factor for uterine sarcoma is pelvic radiation. Two leading risk factors for hepatocellular carcinoma is cirrhosis plus hep B infection. Most important prognostic factor for breast cancer is axillary lymph node involvement and then tumor size. Most important prognostic factor for cervical cancer is stage at the diagnosis and then whether there's pelvic or para-aortic lymph node involvement. Favorable prognostic factor for ALL is a T1221 translocation. Most important prognostic factor for Hodgkin's lymphoma, clinical stage, not the histologic type. Most important prognostic factor in renal cell carcinoma, invasion of the renal vein. Most important prognostic factor in melanoma, invasion of depth. Most likely bone for mets from cancer elsewhere is the vertebral column. Most likely bone mets to the vertebrae is typically breast then prostate. Brain mets, most likely primary is lung cancer. Lung mets, most likely primary is breast cancer. Future malignancy in retinoblastoma is osteosarcoma. Most likely primary in a child with multiple bone mets is neuroblastoma. Most common neoplastic complication of HIV is Kaposi sarcoma. Cervical, anal, head and neck, vocal cord cancers cause is HPV. most common. Bacillary angiomatosis caused by Bartonella Hensley. Hodgkin's and Burkitt's lymphoma caused by EBV. Post-transplant lymphoma, EBV. Mucosa-associated lymphoid tissue lymphoma, H. pylori. Hepatocellular carcinoma, Hep B, Hep C. Most common cause of thrombocytopenia in healthcare setting, heparin. Most likely malignant complication after radiation is acute leukemia and then papillary thyroid carcinoma, as we discussed, if there was radiation to the head and neck. Most serious complication of sickle cell disease, acute chest. Most likely trigger of a hemolytic episode in G6PD deficiency, acute infection. Platelet dysfunction, most likely presenting with nosebleeds or just mucocutaneous bleeding. 55-year-old male with a hemoglobin 8 and an MCV of 60, concern for colorectal cancer. Infectious disease. Most important opportunistic pathogen in the transplant patient, CMV. Most likely cause of transplant rejection, acute rejection. Most likely malignant complication of chronic immunosuppression is squamous cell carcinoma of the skin. Most common cause of infection overall in a transplant recipient, CMV. Most common cause of infection in a solid organ transplant, Candida. Most common cause of infection in a bone marrow transplant, Aspergillus, which you would then treat with voriconazole, and then the second most common is Candida. Most common HIV type in the US is type 1. Most likely mechanism of HIV transmission in the US is men who have sex with men. Most likely cause of HIV in healthcare workers is a needle stick injury. Most common cause of blindness in HIV is CMV retinitis. Most common cause of skin abscess is Staph aureus. Most common complication of perineal cellulitis is necrotizing fasciitis. So when treating necrotizing fasciitis, oftentimes you want to also include clindamycin in the regimen for the antitoxin effect. Diabetic with sinus mucor, amphotericin B plus extensive debridement. Most common cause of impetigo, Staph aureus. Most likely clinical presentation of superficial dermatophytosis is tinea pedis. Most common cause of folliculitis, Staph aureus. Tinea capitis, often you'll treat it with an oral itraconazole or terpentine. Most important test to diagnose infective endocarditis is a blood culture. Two leading risk factors for C. diff colitis is hospitalization and antibiotics, long-standing, typically IV. Most common cause of infection in burn patients is Pseudomonas sepsis. Most common cause of infection in burn patients is Pseudomonas. Most likely clinical presentation of a military patient with anthrax, cutaneous anthrax. Patient from Hawaii with conjunctivitis, you want to think leptospirosis. Most commonly sexually transmitted infection in the US, chlamydia. Among the causes of vaginitis, the sexually transmitted one is trichomonas. The most important factor in tuberculosis successful treatment is adherence to the regimen. Infectious complication of chronic granulomatous disease is pneumonia, typically with catalase positive organisms. Most likely infection transmitted by blood transfusion is CMV, often thought to be Hep C, but that's wrong. It's CMV. It's gone down a lot since we've been washing our blood cells better, but historically CMV has been the answer. Any CNS infection, most likely mechanism is through the blood. Most common cause of vitamin K deficiency in a hospitalized patient is antibiotic use. Okay, here I have endocrine, rheum, and bone and MSK. So glycemic control reduces microvascular complications of retinopathy, neuropathy, nephropathy, And now newer data is starting to show macrovascular. I just wanted to point this out because historically we've always said microvascular and not macro, but new data is showing macro as well. Risk factors for peripheral neuropathy in the US, diabetes. Risk factors for hypoglycemia in the US, alcoholism. Most common complication of type 1 diabetes is insulin-induced hypoglycemia. Most likely clinical manifestation of Paget's disease, bone pain. Leading modifiable risk factor for knee osteoarthritis, obesity. Most important non-pharmacologic intervention on osteoarthritis, exercise. Important modifiable risk factor for osteoarthritis, obesity. Two biggest risk factors in carpal tunnel syndrome is pregnancy and then rheumatoid arthritis. Most likely cause of knee pain in a patient that's under 45 is patellofemoral pain syndrome. Most likely cause of inferior heel pain is plantar fasciitis. Most common presenting complaint in scleroderma is Raynaud's phenomenon. Most likely clinical presentation of myasthenia gravis is ptosis. Most likely initial presentation in rheumatic fever is migratory polyarthritis. Most serious complication and cause of acute death in acute rheumatic fever is carditis. So pancreatitis, we're thinking myocarditis, pericarditis. And then this chronic rheumatic valvular disease can drive long-term mortality as well. Most common extra-articular manifestation of ankylosing spondylitis is anterior uveitis. Most likely clinical presentation of relapsing polychondritis is red, hot, painful ear. All right, in this next group, we have neurology, ophthalmology, and dermatology. Most likely mechanism of status epilepticus, low level of the anti-epileptic drug. So this is typically they're on a medication and either they're not adhering it, that's why it's low, or there's an interaction with another drug that's causing it to be processed faster. Leading risk factor for intracerebral hemorrhage, hypertension. Most common cause of non-communicating hydrocephalus in a neonate is stenosis of the cerebral aqueduct. Most common cause of rapidly progressive dementia is CJD. Leading risk factor for optic neuritis is MS. Complication of Sturge-Weber syndrome is seizures and developmental delay. NF type 2, you want regular hearing screening plus annual MRIs, starting at about age 10 into their 4th decade. NF type 1, you want to screen for optic nerve gliomas. Most important prognostic factor for retinal detachment is time to surgical repair. Most common cause of the retinal disease in the elderly is macular degeneration. Leading risk factors for pressure ulcers is immobility. Most important prognostic factor in preserving neurologic function and cord compression is early diagnosis. Most common cause of blindness in the elderly is macular degeneration. Most important intervention to reduce ocular complications in measles is vitamin A supplementation. Leading risk factor for squamous cell carcinoma of the skin is sun exposure. Most damaging UV radiation to the skin is ultraviolet B. Most common malignant complication in kidney transplant is squamous cell carcinoma of the skin. Most likely outcome of actinic keratosis is resolution, self-resolution. Most likely subtype of melanoma in dark skin patients is the acral litiginous melanoma. Leading risk factor for suicide is prior suicide attempt. Most likely inciting factor for erythema multiforme is recurrent HSV infection. Most common inciting factor for toxic epidermal necrolysis, or TEN, or Stevens-Johnson syndrome, is medication-induced. Most likely barrier to wound healing is persistent infection. All right, now we have OB/GYN, breast, and perinatal. Risk factor for Asherman syndrome is uterine curettage, or D&C. Most common cause of infertility is ovulatory dysfunction, or polycystic ovary syndrome. Leading risk factor for endometriosis is family history of endometriosis. Most likely mechanism for endometriosis is retrograde menstruation through the fallopian tubes. Leading risk factor for female infertility/ectopic pregnancy is PID with scarring. Most common cause of ovarian mass in pregnancy is a corpus luteum cyst. Leading risk factor for preeclampsia is prior preeclampsia and nulliparity. Leading risk factor for placenta previa is prior C-section. Leading risk factor for ectopic pregnancy is prior ectopic and then also smoking. Most common cause of placental abruption is trauma/cocaine. Most common cause of DIC during pregnancy is placental abruption. Leading risk factor for placental abruption is prior abruption or hypertension. Leading risk factor for intrauterine growth restriction is history of growth-restricted gestation. Pregnancy complication of antiphospholipid antibody is recurrent spontaneous abortion. Most common complication in the first 20 weeks of pregnancy is spontaneous abortion. Leading risk factor for chorioamnionitis is prolonged rupture of membranes. High yield risk factor for preterm labor is BV. Leading risk factor for cervical incompetence is a conization procedure or a loop excision. Most reliable indicator of successful labor induction is the Bishop score. Leading risk factor for preterm labor is prior preterm labor, and then you also have Gardnerella vaginitis. Prior infection of premature rupture of membranes is minimalization of cervical exams. Leading risk factor for uterine rupture is uterine scar from a prior C-section. Leading risk factor for chorioamnionitis is premature rupture of membranes, and then next step is group B strep prophylaxis if it's over 18 hours. Intrapartum penicillin for prophylaxis group B strep indications would be prior infant with group B strep, sepsis, positive urine group B strep, unknown status, rupture of membranes greater than 18 hours, or intrapartum fever. Leading risk factors for endometritis, C-section. Leading risk factor for uterine inversion, prior inversion. Leading risk factor for fetal macrosomia, gestational or pre-existing diabetes. Leading risk factor for shoulder dystocia, fetal macrosomia. Leading risk factor for postpartum depression, history of depression. Leading risk factor for postpartum endometritis is recent C-section. Leading risk factor for pelvic septic thrombophlebitis is prior postpartum endometritis. So leading intervention to prevent necrotizing enterocolitis, intraventricular hemorrhage, and neonatal respiratory distress syndrome is steroids, so antenatal, typically betamethasone. Leading risk factor for fetal tachycardia is maternal fever. Leading risk factor for postpartum hemorrhage is uterine atony. Most common cause of hypertension in a young reproductive age female is OCP use. A baby of a diabetic mother in the first hours after of birth is concerned for hypoglycemia. Most common complication of cleft lip/palate is chronic otitis media problems and speech problems. Leading risk factor for cervical cancer is HPV. Most common late adverse effect of pelvic radiation is vaginal stenosis. Leading risk factor for squamous cell carcinoma of the vagina is HPV. Leading risk factor for vulvar carcinoma is HPV. And if it's not listed, you can say lichen sclerosus, and then the next best up is a punch biopsy. Leading prognostic factor for breast cancer is axillary lymph node involvement. Gestational trophoblastic disease with the worst prognosis is Mets to the liver/brain, very high beta HCG, or longer interval from pregnancy. Leading prognostic factor for vulvar cancer is lymph node Mets and then lesion size. Leading prognostic factor for endometrial cancer is stage. Most common complaint is the vaginal bleeding. Leading risk factor for breast cancer is increasing age. Two risk factors for gestational trophoblastic disease is nulliparity and then extremes of maternal age. Most likely initial presentation of cervical cancer is abnormal vaginal bleeding. Now we have preventive screening, medicine, toxicology, and then other causes of death. AAA screening. Men who are 65 to 75 who have ever smoked, and then you want to do surgery if the aneurysm is greater than 5.5, or if the growth has grown over by 0.5 centimeter in 6 months or 1 centimeter in a year. Okay, so breast cancer screening is split by 2 different recommendations currently. So you have the U.S. Preventive Services Task Force, who recommend mammograms every 2 years starting at age 40 through 74. And then the American Cancer Society says annually from 45 to 54, and then you have the option to begin at 40, and then you do every 2 years from 55. Cervical cancer screening. So you want to do cytology every 3 years from 21 to 30, and then HPV co-testing every 5 years. And most of the guidelines endorse this, but the American Cancer Society recommends HPV cancer screening actually start at 25 instead of 30. Colon cancer screening, you want to do every 10 years starting at age 45. And then this is for people that have normal average risk. Then if you have history of UC, you want to begin 8 years after diagnosis, and then you would get it every 1 to 2 years. And then if you have a family history of colon cancer, then it's 10 years before the relative's diagnosis. If you have a history of FAP, then you want to do annually starting at age 10 to 15. Lung cancer screening. So this is when you do a low-dose CT, and you would get it annually from ages 50 through 80. Typically recommended for people who have a pack year history of greater than 20 current smokers or who have quit within the last 15 years. Most important prognostic factor for cancer is the tumor stage. Leading prevention of hepatocellular carcinoma is Hep B vaccination. Hyperlipidemia screening, men every 5 years starting age 35 and women every 5 years starting age 45. All pregnant women at their first prenatal visit should screen for syphilis, aseptic bacteriuria, and then HIV. Most common cause of cyanide poisoning is house fire. Most common cause of death for people ages 1 month to 1 year is sudden infant death syndrome, or SIDS. Most common death of ages 1 through 44 years is motor vehicle accidents. When you hear a 25-year-old male who's 6 foot infertile with a micro penis, it's Klinefelter syndrome. Most likely serious complication of increased intracranial pressure is brain herniation. Most common complication of blood transfusion in the first 6 to 12 hours is a transfusion reaction due to circulatory overload. And then this is typically seen in patients who have CKD mode. Diabetic with right upper quadrant pain, you want to think gangrenous cholecystitis. And then if they do have it, then you would do emergent cholecystectomy. And that's it. So I hope this was very helpful for you. Feel free to check it out as often as you have to. Once again, if you want access to these actual slides and a way to review this cheat sheet much faster, you can check out StudyCCS. Once again, everything's included in the package, and the whole goal is to just consolidate all the high yield resources plus some of the best CCS cases out there. And so that you have all of the resources you need. Plus, I'll leave a 20% discount code in the comments. If you have any questions, feel free to reach out. If there's anything I have incorrect, please put that in the comments so others can also learn from it. But I hope this was helpful.